Babar, we can start. Babar. Babar, we can start now.
Dr. Babar is on mute.
Babar. Babar, unmute.
Yes, ma'am.
Now we start.
Good evening, respected speaker sir, Brij Agrawal sir, my teachers and the seniors and dear participants. Today we have three lecture in webinar CME from ASI on platform of ASI Rajasthan chapter. And for that, I request our President, Dr. Salu Gupta ma'am, give a welcome word and invite our first speaker. Over to Salu Gupta ma'am.
Good evening, everybody. I welcome you all. Today we chosen the topics which are we dealing in our daily practice. like benign breast disease, which is a very common problem, and the most of the women are coming us with the complaint of the mesalgia, pain in the breast, and they are whenever they have pain, they suffer, they think they have a malignancy. So we this topic is very common, and another topic is on the star procedure. Star, so we call an expert from the star procedure, Dr. Brij Agrawal, and ODS, you all know, is a obstructive defecatory syndrome, and SR procedure is for the when the cause is rectocele and the interception. So, and our third topic is on the laparoscopic CBD exploration. As you all know, on the CBD exploration we can do by the open procedure, endoscopic procedure, and by the laparoscopically. If we are doing, so it is better we are doing in a single sitting with the laparoscopic cholecystectomy with the laparoscopic CBD exploration. So now we start our first topic on the STAR procedure, and I invite Dr. Brij B. Agrawal. He is a senior consultant and professor in Department of Laparoscopic and General Surgery in Sir Gangaram Hospital, New Delhi. And sir is in the expert in the STAR procedure. He is doing lot of STAR procedure. And if you have any question, please put in the chat so we can ask the speakers. Sir, please.
So I share my screen.
Yes, sir.
So, good evening, everybody. I bring greetings from my institution, Sir Gangaram Hospital. I offer my thanks and gratitude to Rajasthan State Chapter of Association of Surgeons of India, which is ably led by Dr. Shalu Gupta, Professor Shalu Gupta, and Professor Bhavar Yadav. And I am blessed to be in company of seniors who have taught generation of students and from whom I have also gained a lot of insights into practice of surgery. So good evening, Dr. Shalu. Good evening, Dr. Bhavar. Good evening, Dr. Prabha and other seniors. And I'll be speaking about indications, techniques, and results of STAR procedure. But I think the most important thing is the idea about ODS or obstructed defecation syndrome. So I have kept ODS slides in the end of my presentation so that if we have time, I would have loved to go into the diagnosis and evaluation of ODS. So once again, gratitude and greetings from my institution and my team and the daily surgeons. My talk is based upon the published literature on ODS and STAR, and some of which, like we have few chapters written ourselves on this topic. Then these are some of the publications which have helped us gain some insight into ODS and true indications of STAR. Because I think initially when we started, we were over enthusiastic, and the results may not have been so good as they are now, but I am confidently saying it that now we select our patients very meticulously without any compromise. And I can assure you, if the patient selection is good, results will be good. And if we do it in a patient in whom indication is less than optimum, then results may not be as good. So before I begin my talk, I pray to all my seniors, colleagues, and friends to take it as a not a one-way discourse, but as Dr. Shalu said, interaction, ask questions. It is a famous shloka from our Vedas, Om Sehna Navavtu Sehno Bhunaktu, which means let us all sit together and listen and talk to each other together. Sahaviryam Karvavahe. Let us all work together with our acts so that our glory increases, our knowledge increases, and both of us mutually benefit without any disagreement. So, as this shloka says, as I said, we will not be disappointed as surgeons if our cases are selected properly following the guidelines. before we start, we always pray to our teachers who made us worthy of talking to colleagues, worthy of serving our patients. So these are some of my teachers, and I bow my hat to them. These are international friends with whom I have gained a lot of experience and who have enabled my journey on ODS and STAR procedure. So topic was STAR indications, techniques, and outcomes. So classical gold standard indication for STAR remains one, that is classical ODS, obstructed defecation syndrome. Why do I say classical? Because ODS is a plethora of syndromes in which patient is not able to pass stools satisfactorily. He or she feel obstruction at the outlet. They feel everything is going down well, except when they feel a block at the back passage or anal orifice. So that is ODS. Now ODS has hundreds of causes. It's known as an iceberg. What we know as surgeons is only tip of the iceberg. So it is from this iceberg that we have to select the tip which will be benefited by surgical interventions, while the majority may not require surgical intervention at all. Another indication for STAR, we have done two cases only of benign strictures of lower rectum following stapled hemorrhoidopexy. Then STAR procedure can also be done, as we have done in one patient in which there was carcinoma and histopathology. Patients presenting with ODS symptoms and justifying all evaluation criteria for diagnosis of ODS and having a localized polyp. Then, sorry, solitary rectal ulcer syndrome. I'm sorry for the wrong writing. Solitary rectal ulcer syndrome is one another indication which is emerging as a popular choice for STAR procedure, and results are quite encouraging. Although STAR is indicated for internal rectal prolapse, as Dr. Shalu said, for rectal interception, but it can be done with any degree of rectal prolapse depending upon availability of an instrument known as mini contour, which unfortunately is not available in India. So the most important thing in selecting patients for STAR procedure is making a diagnosis of ODS. There are various scores for ODS, and in India we have found this score to be quite useful, and it has been accepted internationally and published. As we know, and constipation patient, apart from constipation, patient may be suffering from straining at defecation, suffering from regular use of laxatives, maybe applying a lot of pressure but still feeling incomplete evacuation, that is no satisfaction, and going to washroom again after few minutes and again after few minutes, so that his defecation is intermittent, fragmented, and he has to go many times, but still there is no satisfaction. And finally, these patients may be taking help of putting in a finger inside the anal canal, or putting in a finger on buttocks and stretching them apart, or in females they may be doing vaginal splinting, putting up a finger in vagina and pushing posteriorly onto the fecal matter in the anal, lower rectum and anal canal. Or there are instances, reports where patients have even put in hand showers or things like that to clean their back passages. And this is a very simple scoring system. It is based upon Likert scale, in which you give 4 points, 5 points, 5 grades from starting with 0 to 4. And if a symptom is not present at all, it is 0. If it is very rare, that is less than once in a month, then you give 1 point. Sometimes means more than once in a month, you give 2 points. Usually means almost weekly, and always means always daily. So if you add up these scores, we have published that if the score is more than 15, then these are the patients who should be evaluated for ODS. If it is less than 15 but more than 10, further investigations may help us. But if it is less than 5, then there is no point in considering these patients for surgical intervention for ODS. Now, as I said, we have to select where should we do STAR, and to select and be intelligent enough to rule out or to exclude patients where we will not like to do any stapled procedure. So as I said, external full thickness rectal prolapse, unless you have experience and a mini contour instrument available, I have not used except once. when it was given for demonstration only. So I will not comment upon this. So this remains an exclusion criteria: external full thickness rectal prolapse. Any infection around the anal canal, whether it is dermatitis, fungal infection, a frank suppuration abscess, or a fistula, that should be treated first. Before that, you should not intervene with star, and once it is controlled or taken care of completely, only then we should reevaluate the patient for ODS. Female patients presenting with ODS many a times are found to have rectovaginal fistula, which they are shy of telling. So we should ask our gynecologist colleagues, or if it is allowed in your practice in presence of a female, then we should exclude the possibility of a rectovaginal fistula. As I said, ODS is a diagnosis of exclusion in identifying the tip of a vast majority of iceberg patients. We must, colonoscopy remains an indication in these patients, because we have to rule out all disease illnesses which can cause altered bowel habits. So colonoscopy, if there is an evidence of proctitis or frank inflammatory bowel disease, we should not operate these patients. Anal incontinence, unless I'm saying there are many causes of anal incontinence, so it is a exclusion unless anal incontinence can be demonstrated to be solely because of internal rectal prolapse. Because as I said, these ODS patients will have plethora of symptoms. So some of these patients might have anal incontinence, something like we have overflow urinary incontinence. Rectum is always full, something is flowing out. So if on examination and evaluation, nothing else but internal rectal prolapse is seen, neurological causes are ruled out, then star procedure is really helpful, and I have a good experience of such patients. Any pathology which reduces the lumen of the anal canal, that is anal canal stenosis, which may be usually post-operative, because some of these patients will come to us with history of having had sex sclerotherapy or hemorrhoidectomy in past. So if there is anal canal stenosis which allows which does not allow the insertion of the stapler, obviously we cannot proceed. But we have dealt these patients by first treating anal canal stenosis and subsequently treating their ODS. Enterocele at rest. So enterocele is a peritoneal hernia inside between the uterus, vagina, and rectum. So it is quite common in females, but if this peritoneal pouch or internal peritoneal pouch has small gut in this peritoneal reflection, then it is a contraindication, because application of stapler from anal canal might cause small gut injury. Again, this is a exclusion, but we operate these patients by putting in a laparoscope from the umbilicus and pulling up the intestines into the abdominal cavity, emptying the rectal pouch, and then star procedure is done under vision. Then patients who have had rectopexy, mesh rectopexy, history of mesh rectopexy, they develop, we know, in irrespective of the procedure adopted for rectal prolapse, up to 40% of patients will have new onset constipation, which is known as de novo constipation. And cause of this constipation may be multifactorial. Usually it is the injury to the nerves, or because of the loss of slide of rectum on the sacrum. Normally rectum slides on the sacrum to help to facilitate defecation. Now when we do a rectopexy, rectum gets fixed to the sacrum, so there is no movement of rectum on sacrum. So that is one of the important pathophysiological mechanisms of de novo constipation. So any patients with history of rectopexy using mesh, they are a contraindication, because by doing a staple transanal star procedure, we might open up the mesh, exposure of mesh into the lumen, leading to failure of healing of the staple line and mesh erosion kind complications. Like all surgeries, uncorrected coagulopathy because of any reason will remain a contraindication or exclusion for star procedure. Now, since we are talking of outcome, so it is very important for a successful practitioner that there is no gap between the outcomes of our procedure and expectations of the patient. Like our surgery should be such कि जो पेशेंट को हमने बताया है, जो पेशेंट आशा करता है कि मैं ऑपरेशन के बाद ऐसा हो जाऊंगा और रिजल्ट वैसे ही हों. So the crux of a successful surgical procedure is to minimize the gap between patient's expectation and our results. So how do we achieve it? We achieve it by informed consent. How do we take informed consent? We take it by informing the patient of all the treatment modalities and the options available to patient, including what we are offering, and telling the patient the advantages and disadvantages of our procedure, plus what the patient should expect from that procedure. So I always say that pre-operative counseling is very important in all surgeries, especially so in surgeries which are new and which are not widely accepted so far, such as star and pop star, etc. So we have already said we have to select patient carefully. We have to have an informed consent. We must discuss complications of procedure or any surgery with the patient. In context of star, they will be starting from post-operative urinary retention to post-operative reactionary or secondary hemorrhage, to staple line dehiscence, to stricture formation, to a cavity formation, to sepsis, from starting from perineum and spreading all over. So we have to give an idea to the patient about all these complications and tell the exact incidence, approximate incidence, and tell that they are there but very rare, and maybe with our experience now we will not see them. And if they are identified in time, we have to tell our patients that we will identify them as and when they happen, and they are easily manageable. So in again, so we have to tell the patient about chance of putting in a urethral catheter after surgery, chance of bleeding or hematoma or staple line formation, or painful defecation, new onset painful defecation. ODS patients do not have pain at defecation like in Fisher in Ano. But suppose after start surgery, patient develops pain, that is a complication. We call it dyschezia. And most common adverse outcome after star procedure used to be fecal urgency. That is, patient used to feel an urge to go to washroom every 1 hour or 2 hours and come back and then again go. So it was quite irritative outcome. And it was later found that it was because of improper training of patient before surgery. So we published our results about this, and we found that yoga training before surgery and after surgery took care of this problem completely. I published yoga, but Westerners now call it biofeedback. And as I said, in female patients, we must discuss the complication possibility of rectovaginal fistula. Again, telling the patient, look, if it is identified on table, it can be easily managed. I have had a patient working in our hospital in which I caused rectovaginal fistula, but thanks to my team, it was identified on table. And thanks to my friend Ronald Scherer, it was long back. I called him up, and he was in Berlin, and he guided me, and I was able to manage it successfully with primary repair. So carrying on to pre-operative counseling, patients are, for any surgery, whether it is star or anything, they usually ask us, doctor, how much hospitalization is required? Will I go?
खाना दे देते सबको काम खत्म.
Somebody is saying something? No. Okay. So normally patients ask us, how long will I have to stay in hospital? As for STAR, we do it as an ambulatory daycare procedure. We send patients usually the next day morning, but almost 25% of patients decide on their own to go back home on the same day of surgery. So we tell them it's a daycare procedure and you will be able to go home a day after surgery. Then the patients usually ask, okay, doctor, मैं खाने वाने में क्या परहेज होगा? Will there be any dietary restriction? So we have published a paper in surgical endoscopy that dietary spices like chilies and all that help in healing. So I never advise my patients to stop any spices after any surgery, including hemorrhoids, because it is a closed procedure. There is no question of irritation. Plus, scientific evidence is there that none of these dietary spices passes unchanged at the back passage. There is no relation between burning, irritation, and spices. What happens is, if there is proctitis, if there is inflammation, anything strongly alkaline or strongly acidic will irritate the back passage. So it is not the spices, even a fecal matter will irritate. So we have published a randomized control trial that there is no need to stop Indian style diet, because half of the mental problem of the patient apart from pain is कि मेरे को खाना पीने में जिंदगी भर के लिए परहेज हो जाएगा. So that is wrong. The next question patients need to be answered at is, when will the first motion pass? Patient usually ask के डॉक्टर साहब मेरे को motion जब आएगी दर्द तो नहीं होगा, कब आएगी? So I tell them you will pass motion within first 48 to 72 hours, and if the procedure is free of adverse events, it should be painless evacuation. In patients in whom we expect some difficulty in passage of stools because of, say, tight anal passage when we were doing surgery, or some staple line hematoma at the time of doing star procedure, or need for taking additional hemostatic sutures, in those patients I advise preemptive stool softener in form of syrup, jufa, like what is lactulose, or what Lexitol. So that answers the question of first evacuation and will it be painful. Then the patients want to know how long will they have to stay at home. First thing was how long will they stay in hospital. The second thing is how long at the home. So I tell them, and for all laparoscopic procedures and transanal procedures which involve no open wounds, these people can go back to their normal routine about 3 days after surgery. I tell many patients that they can start working on the same day, but that is not practical. I tell them you will feel some rawness, some heaviness, some mental difficulty in accepting that you have undergone surgery and you are back to work so routinely. So I tell them that 2 or 3 days with your family will make you psychologically positive and feel strong enough to go back to work. And we assure them that there is no question of there is no question of surgery or surgery outcome causing any staying away from work, unless there is a complication which we as surgeons will be able to know on table itself before discharge. So in those patients we tell them, look, your stapler, there was some bleeding, or there was some hematoma, collection of blood, or I had to take additional sutures, or we can say your what I wanted to resect was the tissue was not 100%. Your prolapse was bigger than what I thought, so it was not 100%. So these are the patients we will say, okay, you wait till I examine you next, and then I'll tell you when you can go back to work. And in any case, even in normal patients in whom we are saying you can go back to work within 3 days, I usually call these patients to my clinic on the third day of surgery, take good history again about their first patches of stools, resumption of diet, their sleep, their feeling of comfort, and how much of painkiller medicines they are needing. And when they are reassured, then I examine them and I do a gentle digital rectal examination. And if I see no hematoma, no swelling, no tenderness at the staple line, then I tell them you can go back to work. Then the patients will ask, doctor, आपको दोबारा कब दिखाना होगा? So what will be my follow up? What will be the chronology of follow up? So I tell them, look, third day of surgery, if there are rich people who want to stay in the hospital, they stay up to 3 days, and then they are called after a week. But normal daycare patients, I tell them you will be coming on third day of surgery, then at 7 to 10 days of surgery, then at 3 weeks to 1 month, and then after 3 months. So the patient feels reassured, and then I tell them this is as long as you remain normal, but some patients might have some fever, some pain at defecation, some discharge from back passages. In that case, please come back to me immediately. And if there is an evidence of infection, the first and the commonest sign that I have found or symptom of infection at staple line is not pain, is not fever, it's not difficulty in passing stool, it is difficulty in passing urine. So I tell them, my patient, if there is any change in your urinary stream or you are not comfortable passing urine, please come back immediately, and then we assess them for bladder outlet obstruction. So this was pre-operative counseling. Now, how do we improve our results of surgery once the patient and surgeon both are in the operation theater? As I said, 20% of patients after any anorectal surgery are likely to have post-operative urinary retention, or POUR. To minimize the POR, there are many techniques. Best thing is never operate under anything except general anesthesia. And second best thing is always ask your patient to empty urinary bladder just before going on operation table, so that the bladder is not full immediately after surgery and patient has recovered from anesthesia and regained strength at the bladder neck to pass urine. So We ask the patient to pass urine before walking to the table, and we walk the patient to the table so minimize chances of deep vein thrombosis. We ensure hemostasis on the table. In initial practice of my stapler procedures, I had two patients within one day who were required to be taken to OT again for hemorrhage. Then I realized that it is good to spend another 5 to 10 minutes after completion of procedure to examine the staple line for any ooze at a good blood pressure. So good blood pressure means we ask the anesthetist what is the blood pressure at the time of completion of surgery. Is it lower than what we started at, or it is higher? It is always a good practice, and I follow this as taught by my teacher 40 years back, that you should start surgery and ask anesthetist to maintain blood pressure and bring it down, and keep on requesting, please lower the blood pressure. And when you are about to complete your surgery, start requesting the anesthetist again, asking the blood pressure, and whatever she says or he says, say, ma'am, is it low? Can we have normal BP? So they get the hint that you want a normal or slightly higher than normal BP. So hemostasis at completion of surgery should be achieved at a normal BP at which we started, or what is normal for the patient, or slightly higher than that. Then as the patients are walked to the table and they are not kept fasting for more than 6 to 8 hours before night, and I give them 2 liters of hot sweet milk the night before surgery, all my patients. This is another trick of my practice. I tell them, you take an early dinner at 7 p.m. 7 p.m. is early in Delhi, and drink 2 liters of hot sweet milk before you go to bed by midnight. And then you come in the morning empty stomach. So what happens? Patient will not drink 2 liters, but he'll get I explain that it will give you fluid, it will give you energy, you will not feel weak in the morning, and the patient has a good bowel motion in the morning. That is the best part. So these patients are not dehydrated, they are not carbohydrate depleted, they are feeling energetic. So we do not give any IV fluids to these patients unless the anesthetist wants, because of hemodynamic instability, which should not be there if we have achieved hemostasis on the table. And as soon as the patient recovers from anesthesia, rather on the table itself, I ask my patients to do some leg cycling. And as soon as he's recovered from anesthesia, we walk them from the bed. And we restrict fluid till the patient passes urine, and we allow normal diet within 2 hours of recovery from anesthesia. So that was during surgery, how to manage your outcomes and optimize your outcomes. Now, what about post-operative? Now, patient, you are in post-operative ward. So as I said, once the patient is out of anesthesia, 2 or 3 hours more, and you give a normal diet, but restrict fluid so that he doesn't fill up the bladder immediately, and there is no retention unless patient was dehydrated. And patient cannot be dehydrated if he has drank enough milk or water or sweet drinks in night. And then we ask the patient to take a normal diet, resume walking, and stop waiting कि डॉक्टर साहब मेरे को मोशन कब आएगी कब आएगी कब आएगी. नहीं, जब आएगी जब आ जाएगी. थोड़ा बहुत दर्द होगा तो we tell them, look, for 3 days you will feel it, after 3 days it should not be there, and whatever little discomfort you have, it should disappear by third week, not after 3 weeks, by third week. That is, I have seen 10 days after surgery there is no pain at all, no feeling at all in this procedure. So what is our discharge advice in these patients? As I said, we discharge after 18 hours of surgery, that is early morning, next day 6 o'clock, or some patients go in the evening, that is hardly 6 to 8 hours after surgery. We tell our patients before surgery to keep in touch with WhatsApp, SMS, or internet, whatever they are comfortable with. And we ask them to maintain a pain record, not a pain diary. Basically, it's a diary. I tell them, लिख लीजिए आपको जब दर्द होता है कि ऑपरेशन के बाद सबसे ज्यादा दर्द कब हुआ था, अगर वो 100 पॉइंट था तो उसके बाद कितना पॉइंट पेन हुआ. देन आई आस्क देम टू मेंटेन अ डेफिकेशन और स्टूल डायरी कि आपको पहले दिन मोशन कब आया था, दर्द कितना हुआ था, मोशन हार्ड था, सॉफ्ट था, हार्ड था तो पत्थर जैसा था, आराम से निकल गया था तो, या आपको फिर दोबारा उंगली लगानी पड़ी थी, थिंग्स लाइक दैट. एंड दीज आर नॉर्मल थिंग्स. नाउ स्पेशल एडवाइस इज कि कुछ भी अलग होता है, एनी एडवर्स इवेंट, उसको जरूर लिख लीजिएगा. सो व्हाट इज एडवर्स? आई सेड यूरिनरी discomfort, dysuria, retention of urine, then fever, or passage of stool without any effort, that is incontinence, which is usually not fecal incontinence, which is staple line hematoma, which is discharging, or which is infection at the staple line. And finally, if there is fever, there is discharge from the back passage, there is dysuria, patient will definitely have bleeding in the second week of surgery. And these are the patient in whom you take enough precaution and start good antibiotics. And the best antibiotic is which covers gram negative and anaerobic bacteria. So we all know coamoxiclav covers gram positive, gram negative, and anaerobes. So you don't have to add matrozole with coamoxiclav. If patient is having significant urinary symptoms and creatinine and renal function was normal,
Nisho?
it's a good idea to
Hey,
add an
Nisho.
aminoglycoside. So now this was indications and pre-operative, per-operative, and post-operative communication with the patient. The second part of my talk was outcomes. So what outcomes cannot be like I say, मेरे results बहुत अच्छे हैं तो मैं खुश हो जाऊं. It's not like that. So what are the metrics or standard tools to measure outcomes? So National Institute of Clinical Excellence in United Kingdom came out with standard guidelines to define expected or reasonably good outcomes in patients operated by STAR for ODS. They said there should be fall in ODS score for more than 50%, which should be maintained at the end of 1 year. So outcome is not decided in a week or in a month. So at the end of 1 year, if ODS score is less than half of what it was before surgery, then you will say outcome is okay. Then, but you cannot wait for 1 year. So what else? The patient should be either free from symptoms, which we talked about, straining, finger evacuation, any physical maneuvering to help defecation, regular use of laxatives, passage of stools, hard, pallet-like, stony stools. So if any of these things is still happening and it is happening more than twice in a month, then the procedure is not successful. And the most important thing they say is all these patients have a significant impact on their quality of life because of defecation disorder. They are not happy. They are not happy going to social functions कि वहां जाएंगे तो मोशन आ जाएगी, पेट साफ नहीं होगा तो क्या होगा, ऑफिस में फैसिलिटी नहीं है. So these kind of problems are there and they are slightly low mood people. So a successful procedure will improve the quality of life in these patients. So there are quality of life scores. SF32 form is there, which is, but in Indian context, we don't need to fill up any forms. Practical thing is from the face of the patients, we all are mature enough to make out whether the patient is happy or not. And the best point of being a patient happy is if a patient brings you another patient, then it means he is satisfied. That is my criteria. And I can tell you that my satisfied ODS patients have brought me a lot of surgical practice otherwise also. So now these are the parameters for a good outcome for ODS. Now, what is the evaluation of STAR, whether STAR achieves these outcomes? Because there is a significant lobby which says that biofeedback, what I call yoga, is a treatment of choice for these. So in randomized control trials, it was seen that STAR scores over biofeedback by a significant p-value. 82% patients were happy after STAR, while only 1 in 3 patients were happy partially with biofeedback. And as we said, this is my result. In our studies, our ODS score reduction after 1 year was 17.8 to 5.8. And our patients, as reported in NICE guidelines also, they had a very good improvement in health-related quality of life. As I said, whatever we may say, we may present papers, write papers, fill up pro forma. The best indication in my practice has been these patients have brought me their family for other problems like gallbladder, hernia, and carcinoma breast, carcinoma colon, whatever. So I have seen that most of these patients, the primary satisfied patient was either a STAR patient or in my practice, a gallbladder patient. So coming second part of talk was results. So these are I was the first one to do STAR in Asia and third in the world after Dr. Longo and Dr. Scherer of Germany. So I did my first case in April 2008. These are the published 67 patients we published. So based upon these 67 patients, we developed our own protocols. We found that STAR was more common in fifth decade of life. In Western literature, there is no mention, not even a single patient of ODS who is male. Their 100% patients are female. But in our practice, two-thirds of patients are males And now this fact was confirmed by my other colleagues in India who do star procedure successfully. In India, male patients are more having ODS. Probably we are selecting our patients more diligently, and female patients do not have ODS because of posterior compartment alone. ODS is pelvis has three compartments: anterior for urethra and bladder, middle for urogenital vagina and uterus, and posterior for rectum and anal canal. So probably Europeans and Americans were focusing on females because these patients will come with perineal syndrome or pelvic floor dysfunction. So pure ODS, now it has been substantiated, is more in males as compared to females. That is why nowadays many surgeons say that rather than doing a star, we should do a laparoscopic ventral rectopexy. Now that is a procedure not for posterior compartment. If the patient has middle compartment prolapse, then star is not a good procedure. Then obviously we have to fix middle and posterior compartment. Then laparoscopic ventral rectopexy is the procedure of choice. So we found, as now has been, we were the first ones to publish, but now it has been shown by other authors, other workers, that it is not the rectocele or anterior or posterior which decides the favorable outcome in uh, star, in ODS with star. It is the rectal intussusception. So now I operate only those patients who have a demonstrable rectorectal or rectoanal intussusception because of internal rectal prolapse. Rectocele, small or big or very big, is not symptomatic as far as ODS is concerned and does not require correction unless it has in females symptoms of sexual dysfunction. So that is not ODS. So for me and for most of the world literature now, indication and diagnostic criteria and the single most important factor for prognostic outcomes, that is favorable outcomes in star, is presence of rectorectal or rectoanal intussusception. So as I said, in our patients, mean scores before surgery were 18, and after surgery at 1 year they were 6. So highly significant. And we found that improvement was equal, almost equal in both genders, male and female, with an insignificant p-value. Then we did a plotted curve, area under curve chart. We found, we measured, radiological thesis was done, and as well as our own studies were done, which have been published by radiologist group in our hospital, that length of rectal intussusceptum was very important. And the calculation showed us that 2.74 centimeter was associated with best outcomes. Even if rectal intussusception is even if you do a good star procedure but length of the intussusception is less than 2.75, your results will not be good. So length of intussusception or intussusceptum, rectal or rectoanal, should be more than 2.74 centimeters to make your outcomes very good, like a straight line, confident that you will achieve good results. So these were 1 year outcomes. Then we published 3 year outcome in around 300 patients. Again, they were very satisfying because we had selected our patients very diligently. But I will add that it is important not to fit one procedure into all patients of constipation, or not to consider all patients of constipation not responding to medical management as candidates for ODS or star procedure. Surgery should not be like a surgeon with a hammer and a nail, कि जहां दीवार में जगह है मेरे को कील ठोकनी है, एक हथौड़ा और एक वो मिल गई, क्या कहते हैं उसको, कील। तो आपके हाथ में, हमारे हाथ में कील भी है, हथौड़ा भी है, लेकिन हमें देखना है कि दीवार में कहाँ ठोकनी है, कहाँ जरूरत है. So technology should not be used blindly across the board. So it is, some famous surgeon has said, a fool with a tool is still a fool. So technology is a tool given to us to improve outcomes in our patients. So provided we select our patients carefully and we exclude our patients who may not benefit from our tool. A tool in this case is stapler, or the procedure is star procedure. So I think this is a repetition, repeating what are the good points, what is the criteria for good outcomes. So less than 50% of ODS scores at 1 year, and not more than 2 events of stool problem in a month. So these findings were first published by German registry. Most of the European countries started having a star registry because registry is a multi-centric data accumulation, and they found German registry outcome was star is a safe and effective procedure. And they don't say safe or effective like an English language. There is a definition of what is safe and what is effective. In scientific literature, we don't use words like, okay, it is very good, it is very long. So that safe means in comparison to any anorectal surgery, the outcomes are not adverse in any parameter. Effective means what I told you, the nice guidelines. So not that we feel in our patient they were happy, it is effective. So there has to be a standard tool. Similar results were published by Italian registry, and they said they were even more, their data was even wider, and they reported that quality of life was also significantly improved. Germans did not study the quality of life. Then there is a combined European registry which talked about improved function, not only safe and effective. Function means patients' defecatory time, style, and post-operative discomfort, frequency, urgency, or incontinence to flatus, because there were concerns in West that star procedure causes some incontinence. Now in India, incontinence to flatus was not there. I was not aware. Then I became aware of it when in West, flatus incontinence was a very major factor कि इनको गैस पास करने में भी अगर कंट्रोल करने में प्रॉब्लम है तो ये एडवर्स आउटकम है. So combined European registry came that it was not there, and star improved overall function, overall health related quality of life at 12-month follow up. But they said further investigations are required to एड्रेस व्हाट आई सेड अर्जेंसी, बार बार मोशन जाना. सो उसके लिए उन्होंने बायोफीडबैक शुरू किया. व्हाट वी पब्लिश्ड आर रिजल्ट्स विद योगा इन सेजेस, and we are now, our patients do not have any urgency. And these there are a couple of studies which say that, as I said, as I have seen and we have published, that results depend upon correction of intersusception, not rectocele. So unless there is an intersusception, we should not operate these patients. So some, again, what are my tricks of the trade? As I said, empty bladder, when the patient is walking to the table, not on the trolley, absolute hemostasis, bleeding का कोई एक बूंद भी नहीं नजर आना चाहिए. सर्जरी के बाद कोई आईवी फ्लूइड्स नहीं, अनलेस के वो डिहाइड्रेटेड है. सर्जरी होने के 1-2 घंटे के अंदर अंदर चलना फिरना शुरू, और जब तक पेशाब नहीं आए उसको पानी नहीं पिलाना है और खाना खिलाना है. So this was our first publication and first Asian publication on star. Now I come to the technique. As I said, I preferred surgery under general anesthesia, whether it is star, whether it is stapled hemorrhagopexy, or a perianal abscess, or a fistula in ano. The point is, we are a teaching institution. A surgeon should teach. So we are speaking on table. Patient is listening to us. Sometimes we are angry with our students, residents. So general anesthesia with good amnesia should be ideal. Second point is, as I said, incidence of post-operative urinary retention, POUR, is less after general anesthesia, because after spinal there is shift of fluids from the peripheral venous pooling to the systemic circulation, leading to sudden filling up of the urinary bladder. So general anesthesia is safe, it is controlled anesthesia. Spinal is not a controlled anesthesia. So first step is general induction of anesthesia, and then introduction of circular anal dilator as you introduce in stapled hemorrhagopexy. Second procedure is confirm your findings of outpatient examination. You can see there is some prolapse, but it is not coming out of the anal canal. So it is internal rectal prolapse, which can be confirmed by a sponge and a holder test. In a normal rectal mucosa and normal lower rectum, mucosa will not slide on examining gauze. So you confirm, and you can see that I will take it back. The anal canal looks wide open, patulous. Unless there is internal rectal prolapse, anal canal will not look like this. And you can make out that this is a male patient, so much of hair. So most of the patients, now even more than 2/3 of my practice patients are males, because female patients have a multi-compartment syndrome. And in those patients, we may have to do a pop star. I still prefer a pop star over laparoscopic ventral rectopexy. So after we have put in a anoscope and examined with sponge and a holder test, confirmed intersusception, we fix the circular anal dilator at 12 o'clock, 3, 9, and 6 o'clock position. And in this, you can see a better demonstration of, you can see internal rectal prolapse, how the rectal mucosa and wall slides and tries to come up to the anal verge, but does not go beyond the anal verge. If it goes beyond the anal verge, then this is not a good procedure for constipation. So first step is, now star procedure is resection of the lower third of rectum. So what is it? Lower 1/9. So that is 10% of the rectum, by dividing it in two halves, anterior and posterior. So we divide the rectum by using pulling sutures so that we can pull it. We call them parachute sutures. Dr. Longo devised this procedure, and when he started doing it, he did the same thing by using two circumferential sutures, like in stapled hemorrhoidopexy, what we call as two purse string sutures. But then I devised this parachute suture. I observed him operating. I assisted him and Dr. Scherer in Berlin. And then I realized we could achieve the same thing by these interrupted sutures. And Dr. Longo saw it and he called them like parachute. The parachute name was given by him spontaneously, but it was devised by me. So I will go back to the video. So after fixing, we pick up the rectal mucosa at 2, 10, and 12 o'clock position. Then we take a bite. First bite is to hold the rectal mucosa, to pull it down, and second bite, or you may even take a third bite, is about 1.5 centimeter inside to the first bite, because rectal wall is 6 to 7 millimeter in thickness, and as you can see, the rectal wall is folding on itself when it is coming down. So there are two rectal layers. So if it is 6 to 7 millimeter one layer, two will be around 1.4 centimeter. So 6 to 7 millimeter multiplied by 2. So we take second bite, which is proximal or inside by 1.5 centimeter. So this was first, and this is number 2. So we take at 2 o'clock, 10 o'clock, and 12 o'clock. It is our own choice whether to start at 2 or 10 or 12. Now this is the recording of my first case of star, and I always show this, and I always tell people this is the only recording, which is not true, but I don't want to show anything else except first case, because I want you to feel like you are doing it for the first time. So you saw 2 o'clock suture we took. Now we have come to 10 o'clock. So first bite, and we are using 2,0 Vicryl. Dr. Longo and Dr. Scherer use either number 1 proline or PDS suture, but I have always used 2,0 Vicryl because I find it easier to use. So first bite you saw was just to pull the rectum down, and second bite is 1.5 centimeter proximal to that. And if you feel, you can take a further bite at 1.5 centimeter, usually in females, in which prolapse maybe a little bit more. So this is bite at 10 o'clock. We have already taken at 2 o'clock. So then we pull these two and take one at 12 o'clock. So this is 12 o'clock. Now I'll go back so you can see the 12 o'clock also. So we are taking at 12 o'clock. So we have taken 3 bites at 10, at 12, at 2. Now when we pull these 3, the half of the rectum, anterior half, should come out. So this is what we do, is we open the 2 limbs of the 12 o'clock. 12 o'clock का जो धागा है उसके दोनों किनारे अलग अलग कर लेते हैं. एक उसका 10 o'clock के दोनों धागों के साथ आ जाता है, और एक उसका 2 o'clock के दोनों धागों के साथ आ जाता है. So Dr. Longo said it looks like a parachute umbrella. So he called it So this is pulling out the anterior half of the internally prolapsing rectum. So now we have to use a circular stapler, which is a full circle. So what will happen is, it will destroy or destruct or cut, without our knowledge, the posterior part. So to protect the posterior part, we have put a tongue depressor through the slot, so that half of the stapler is wasted. It is not used in cutting. So as you saw, we divided ये धागे 2 o'clock के दोनों और 12 बजे वाला एक, और 10 बजे वाले दोनों और 12 बजे वाला एक. ये हमारे 2 सेट हो गए. जैसे MIPH में वो स्लॉट में से निकालते हैं, ऐसे हमने इनको निकाल लिया, दोनों को साइड वाले से. 10 o'clock और 12 o'clock को लेफ्ट साइड वाले से निकाल लिया, और 12 o'clock और 2 o'clock वाले को राइट साइड वाले स्लॉट से निकाल लिया. ये फर्स्ट केस जब हमने किया था, तो I did it using PPH03 instrument because in 2008 PPH01 was not introduced in India. So it doesn't mean that you should start doing it with PPH03. After PPH01 was made available, I have not used PPH03 for star. But as I said, I wanted to show you my first case, the amount of bleeding, amount of messiness, and my tremors of uncertainty. So PPH03 के जो staple होते हैं वो थोड़े पतले होते हैं. Staple height is less. So what happens? Star is a full thickness resection. Stapled hemorrhagopaxy is only mucosa. So इसमें we need thicker, higher standing staple so that full tissue can come. So if we are using PPH03, staple छोटा है, टिश्यू ज्यादा है, तो वो कट थ्रू हो जाएगा, तो ब्लीडिंग होगी, या वो पूरा टिश्यू नहीं आएगा. So it is not good to use PPH03. I was aware of this problem, but then I thought, and I did, that I will reinforce the staple line with sutures. So you just saw that we pulled the sutures from right and left slot, introduced the stapler after putting in a spatula or a tongue depressor at the 6 o'clock slot to protect the posterior part of the rectum, which will be resected separately. And then we tightened the stapler by pulling these parachute sutures. जैसे उसमें करते हैं टाइट, उसको कर रहे हैं. And then we will fire once the number 4 is at anal verge. So fire किया, and निकालते वक्त we rotated. So we have cut the anterior half of the rectum. Posterior is not cut because it was protecting the stapler action. Sometimes what happens, or rather most of the times, because it is a half circle resection, tissue of anterior half will join here, leading to what we call as dog ears. So what to do with dog ears? Now you will see. These are the dog ears. They are divided between two hemostats. So there is, otherwise there will be bleeding. Catch the dog ear between two. This is bridge of tissue. So bridge of tissue, because stapler was पूरा सर्कल और हमने काटा आधा है, तो पीछे से वो जुड़ गया टिश्यू, तो उसको एक पुल सा बन गया, ब्रिज जॉइंट. तो उस जॉइंट को काटा तो दोनों तरफ डॉग ईयर्स बन गए. ये एक बन गया, एक इधर एक बन गया. तो इनको हमने हीमोस्टेट में पकड़ा और hemostatic suture ले लिया, transfixation, like we do any blood vessel control by transfixation. Usually the gynecologists are best in doing uterine artery transfixation. So this was anterior half of prolapsing, internally prolapsing rectum being resected, and posterior half was protected by putting in a tongue depressor through this slot, so that half of the staple is not used. Because staple is circle, we are cutting half, तो टिश्यू फ्रॉम द पोस्टीरियर हाफ यहाँ पे आके जुड़ गया जहाँ पे टंग डिप्रेसर नहीं था. जो जुड़ गया उसको टिश्यू ब्रिज कहते हैं. जब उसको काटा तो उसको हम दो डॉग ईयर बन गए, जिनको हमने हीमोस्टेट में पकड़ के और ट्रांसफिक्स कर दिया ताकि हीमोस्टेसिस हो जाए. सो ये एंटीरियर हमने कर दिया. अब आ जाते हैं हम पोस्टीरियर पे. वही सेम प्रोसीजर. एंटीरियर वी हैव डन. Posteriorly, we will take bites at 6 o'clock. As you can see, first bite by holding the tissue in tissue forceps. So first bite is just to pull it. Now you see second bite goes 1.5 centimeter proximal, so that we are taking full thickness of the rectum. So this is 6 o'clock. We will take the similar bite at 8 o'clock, 4 o'clock and 8 o'clock. उसमें हमने 10 2 लिया था, तो 8 और 10 का टिश्यू जो है बीच में, दोनों स्टेपलर के बीच में वो टिश्यू ब्रिज बनाता है, तो इसलिए हमें करना नहीं उसको चिंता. So this is 8 o'clock bite. Again, first bite, second bite, and then we will take a third bite also if we are not happy with the second bite. Idea is to pull in at least 1.5 centimeter. You see, so I'm taking the third bite here. I was not happy with second. So again we have taken 4 o'clock, 8 o'clock, 6 o'clock, and now we have put the tongue depressor at 12 o'clock, so that stapler will not cut our already resected part. It will not disturb the staple line. So again these parachutes, the 6 o'clock suture, 6 बजे वाले 6 o'clock suture के दो धागे थे, वो राइट लेफ्ट हो गए. राइट वाला 4 o'clock के साथ चला गया, लेफ्ट वाला 8 o'clock के साथ चला गया. तो तीनों एक तरह से पैराशूट की तरह हम अब इसको खींच रहे हैं. नाउ द 3 threads are taken out from right side, which is 4 o'clock के दो और 6 o'clock का 1, और 8 o'clock के दो और 6 o'clock का 1 हम उसके लेफ्ट स्लॉट से निकाल रहे हैं. ये निकल गए. फिर हमने इनको पुल करना है, लाइक इन स्टेपल्ड हेमोरैगिडोपेक्सी. So this is right slot, that is two threads of 4 o'clock and one of 6 o'clock. So then we pull it so that posterior part of the rectum will be pulled into posterior prolapsing part. So you can see how much of rectum is prolapsing. So now this is pulled into, and this is how we measure. You see, this is the we put a scale and we measure now. So then you tighten it till you see the stapler marking 4 is gone beyond anal verge, and then you fire and take it out by rotating so that you are not avulging any tissue. So you have to rotate more than now. Again, you see there is a tissue bridge again forming anteriorly. So we call that, we manage that like we manage the tissue bridge anteriorly by catching it in the hemostat. यहाँ पर इसको पकड़ लेंगे काट के और फिर उसमें hemostatic suture लगा देंगे. Now what can happen? What can go wrong? We examine कि हमारा our staple line is intact or not. Is our tissue bridge divided or not? Is there a bleeding or not? If there is any bleeding, we take an additional hemostatic suture as I am taking in this patient. No, we are dividing the tissue bridge in this video. You can see anterior tissue bridge जो दोनों तरफ से टिश्यू जुड़ गया, सर्कल स्टेपलर इज सर्कुलर और हमने काटा आधा है तो टिश्यू ऐसे जुड़ जाता है. सो इसको हमने काट दिया और इसको हम हीमोस्टैटिक बाइट ले रहे हैं, just like we did in anterior half resection. So the anterior and posterior are mirror image of each other. After we achieve this, then we have to check this is tissue bridge ka dog ear divide. Then we check the hemostasis on the staple line. After the hemostasis is ensured with additional sutures, usually they require additional sutures at 3 and 9 o'clock. We examine the resected donuts. The size of donut is not important. Initially, we thought bigger the donut, patients will be very happy. No, it is not so. It is the full thickness. What is more important is the donut should have perirectal fat. Rectal wall does not have any fat. There is fat beyond serosa, the mesocolon, mesorectum. So if our donut has rectum on the serosal side, mucosal side is inside. So that means we have resected full thickness of rectum, as you can see in this, and that is a procedure which is required for fixing the rectum, because when it is full thickness, when serosa is divided and serosa is resutured or stapled, there is micro leak from that staple line which initiates inflammation and which fixes the staple line to the surrounding tissue, and that fixation, like in suture rexopexy or mesh rectopexy, prevents prolapse. Now this is a circular single line fixation. It's not like a mesh long, so that it is not disturbing the slide of the rectum on the sacrum. Rectum can slide on the sacrum. Nothing is fixing it to the sacrum. It is only the junction of the anal canal with the rectum which is fixed at the level of levator ani, levator plate. So that is the beauty of this procedure. So message from my this technique talk is still remaining if time is there, that we never realized. I was the first one to describe digital evacuation for defecation. There was a patient from Nathdwara in Rajasthan, and he said, "Doctor, I will commit suicide." And he was the patient who taught me ODS, because I had come from watching Dr. Scherer and Dr. Longo, and I had given a short note presentation about this, probably in Jaipur itself, Dinesh Shah. So that patient heard it and he came, and he was the first patient. He said, I would have committed suicide if I was not treated. This was the first. The video shown was of that male patient only. So it is a very common presentation in our society and in males. Western literature says only females. And all surgical procedures, there are more than 140 procedures described for rectal prolapse, including internal rectal prolapse, more than 140 in literature. So none of them have been shown to be useful in ODS or rectal ulcer syndrome. Surprisingly, STAR has very good results if we select our patient. So the key to STAR, as in any surgical procedure, is careful patient selection. So because, as I said, and because as literature says and we have published, the benefits of STAR in properly selected ODS patients having intrarectal intussusception are so good that we should not be denying these patients a good quality of life. So ignoring these outcomes or ignoring lessons from these outcomes by saying the star is not a good procedure, biofeedback should be done, rectopexy should be done. That is a mistake. By doing that, we are ignoring the goodness that we can provide to these otherwise miserable patients. So we should evaluate our patients, but we should, as a surgeon, as I said, कि हाथ में हथौड़ा और कील आ गया तो ये नहीं बस अब थोकना है कील, मेरे को मिल गया स्टेपलर या मेरे को रोबोट मिल गया तो मैंने करना है बस ऑपरेशन. That is not the right approach. The keel and hathoda should be used to hang a painting on the wall. दीवार में जहाँ जरूरत है वहीं पे कील ठोकना है, ये नहीं कि कील को खत्म करना है. So we have to remember that one operation does not fit all. And most of the patients do not require surgery. Most of the patients require your understanding, your hearing, your compassion, and your guidance, and your training for proper lifestyle. So, do I have time?
Sir, now time, because there are two more lectures, so please.
So I am done. As I told you,
Yes.
because you gave me topic of indication, technique, and outcomes. But I
Yes.
thought ODS management is more important evaluation. So I kept those slides in the end. So I will skip them. Okay.
Okay, sir. Okay. Thank you,
I
sir.
will skip them and come to my last slide to say thanks to everybody who was present, to give your precious time and understanding and lend your both the ears to my erratic talk. And I'm sorry if I caused some disturbances, or if I was not proper, or you could not understand what I said. So sorry for that, and thank you for listening to me. And I will repeat once again, which I tell my team. Team for me is TEAM. Together, everyone achieves more. So teamwork. So I say technology is not a wonder, it's not a magic tool, it's a enabler. You have to be an imagination driven engineer, otherwise a fool with the tool is still a fool. I had written an editorial in surgical endoscopy. I think I'm the only Indian to have been invited to write editorial for surgical endoscopy. When I coined this word imagineer, I stands for innovations. As a surgeon, we should continue innovations. M stands for molecular understanding. Science is now molecular based. We should, as a surgeon, should not shy away from studying cytokines. A is ancient wisdom. हमारी पुरानी बातें अच्छी हैं, उनसे हमें शर्माना नहीं चाहिए कि इसबगोल खाओ, सलाद खाओ, हल्दी ज्यादा खाओ, और सुबह जल्दी उठो, शाम को जल्दी सो. अब नोबेल प्राइज मिला है सर्केडियन रिदम पे 2017 का. जी, we should respect the genetic profile of an individual, and now there is an evidence that a patient is happy if he takes the same meal food which his ancestors were taking. I is information technology. Make good use of information technology, as we did today by having seminar, webinar, whatever you call it, without seeing each other, and rather learning more. N is nanotechnology. Use good instruments, and now instruments are getting miniaturized and more effective. So engineer your approach with innovations, molecular understanding, ancient wisdom, genetic understanding, information technology, nanotechnology, and robotics if when needed. Like we were the first one to robotic whipples in India. So when it is to be used, it should be used. So be an imagineer, imagination driven engineer. So thank you very much once again. Ram Ram.
Can you ask one question, please, sir? Only one question.
Yeah, sure.
Yeah. So I'm Dr. Rajkumar from SDMH Hospital. I just want to know about this problem of having enterosil with rectosil with ODS. What should be done in that case? Like, should enterosil be repaired first and start procedure late on later dates, or what should be done?
That's a very good question. And so once we are sure that we are dealing with ODS and patient throws off an enterosil and rectosil on MR defecography, then as I said, enterosil is a contraindication for STAR, because STAR is a blind procedure from anal canal, transanal. So we will not be able to see whether we have injured the gut or not. So unless we put a laparoscope from above and our team member is looking from above that no gut is coming into the peritoneal reflection, we should not do STAR. If we have a laparoscope available, if we have somebody in our team looking up and pulling the gut out of the peritoneal seal, we must do a STAR procedure. Antroseal repair, none of the procedures is successful, and it is not supposed to be repaired nowadays as long as we can correct the internal rectal prolapse, or we can repair the pelvic floor dysfunction. Mostly these patients with enterosil will be females. mostly they will have a middle compartmental syndrome or middle compartmental failure, and they will have a cystocele or a, as you said, rectocele is there. So these patients need a fixing up of middle compartment also. So maybe not star, but a pop star, pelvic organ prolapse surgery with star, be useful for them. But Dr. Longo, Dr. Scherer, and myself and my team member, and I have a very good, young, energetic colleague, Dr. Neeraj Hamija, who does everything like I do. And so we are in favor of Popstar, but other surgeons are doing laparoscopic ventral rectopexy, which according to evidence is equally good. But I am against putting in a mesh in the between rectum and sacrum, as I told you. And I keep on getting calls from friends from Jaipur, from Surat, from Ahmedabad, that the rectopexy patient has not improved. What should we do? What should not we do? So putting a mesh between rectum and sacrum, according to me, is unethical and criminal, as long as it can be avoided. So it can be avoided in female patients by doing a pop star. It can be avoided in male patients by doing a star with a suture rectopexy, whatever, in alone or combination. So you're coming back to your question. Antrocele is not a contraindication, absolute contraindication for star. Theoretically, it is, but nowadays we are all good laparoscopic surgeons. So put in a laparoscope from the umbilicus, have a look, and don't fire your stapler unless you have taken small gut out of the antrocele. But if the female patient is having antrocele, think of middle compartment prolapse, that is cystocele, genital prolapse, vaginal prolapse, whatever. So repair the middle compartment also according to your expertise and your choice of procedure. Our choice of procedure remains pop star or pelvic organ prolapse surgery with star, in which we do not put any mesh between rectum and the sacrum. We put mesh totally extraperitoneally, like we do in TEP repair of inguinal hernia. So there is no mesh in contact with any viscera or in intraperitoneal space. And mesh is also a band, 1 centimeter long band, not big. Thank you.
Okay, thank you, sir. Thank you, sir.
Thank you, sir. Sir, one more question. What is the ideal age for the star procedure? Whether there is any ideal age or in every age we can do it?
No, there is age has no relation with ODS. ODS can be present in any age group, but as I said, literature also says it is seen mostly in fifth decade of life. In females, it is seen mostly in postmenopausal age group, but that is a European experience. I will say in postmenopausal females, it's not ODS alone; it's middle compartment also. So not star, but pop star. In but ODS is usually a problem of fifth decade onward. I have seen very few patients below 30 years of age. But if it is there, if you can substantiate it, then you must operate.
Thank you, sir. Thank you, Brice, sir, for your
Thank you very much, sir.
excellent
Thank you, sir.
lecture.
Thank you. Thank you.
And
Thank you, Shalu ma'am.
thank you, sir. Now the second lecture, I invite Dr. Ramesh Ardhanari, sir. Sir, am I audible?
Yeah.
Good evening, sir.
Good evening. Can you hear me?
Good evening,
Yeah,
Dr.
yeah.
Ardhanari.
Yeah. Good evening. Can you hear me?
Yeah, yes, sir.
Good.
So, sir, the next lecture is by Dr. Ramesh Ardhanari, sir. Sir is head Department of Surgery and Gastroenterology at Meenakshi Mission Hospital and Research Center in Madurai. Sir is a well-known GI surgeon. Sir is past president of AMASI also. And the today's topic is laparoscopic common bile duct exploration. So now over to Ramesh Ardhanari, sir.
Thank you, Dr. Bhamar. It's really a pleasure to talk to Rajasthan ASI, especially you in Jaipur, because in my career, two important occasions as president of Hamasi and as president of Hamasi, the meeting was held in Jaipur when I presided over the meeting. And also, I gave my Colonel Pandalai oration in Jaipur in the ASI in 2017 December. So it's a place with very fond memories for me. You've asked me to start talk on laparoscopic management of CBD stones. So when we talk of common bile duct stones, we know that 10 to 15% of patients with symptomatic gallstone disease will have common bile duct stones. So a significant percentage have common bile duct stones. As of today, the principle is that common bile duct stones present at the time of cholecystectomy should be cleared prior or at the time of cholecystectomy. There are some people who have seen small stones and left them alone. But by and large, even small stones while passing out can cause acute pancreatitis, biliary pancreatitis, and I think it's wise to try to clear them with our present knowledge. So stones left behind may cause pain, may cause obstructive jaundice, cholangitis or pancreatitis, and the most dangerous complication would be pancreatitis. So the detection of common bile duct stones and its optimal management has become very important, especially in the last 2 decades, where laparoscopic common bile duct exploration has come up in a fairly big way. So let us look at the management alternatives for patients with common bile duct stones. What all can we do? We can have laparoscopic alone, do the cholecystectomy, and just wait. But as I said, 10 to 15% is a large percentage. If there are only 1% of patients having CBD stones, this might be acceptable. But 10 to 15%, not acceptable. The other would be that all patients who would have preoperative MRCP or ERCP, certainly all patients cannot have ERCP. ERCP is a procedure with complications, pancreatitis, perforation, bleeding, and therefore cannot be taken lightly. So I don't think it can be done unless you have proved or you're reasonably sure that there's a stone. To make all patients undergo an MRCP preoperatively would make it a more expensive, and all MRCPs are not in Indian situation because our radiologists are still not specialized and they are reporting on brain to foot to leg, pelvis, everything. Their ability to diagnose small stones and be very critical in a bile duct is not the equivalent of what you see in literature, where people who talk of bile duct and stones and all specialize into the hepatobiliary tract and don't do any other radiology. They do only this. So we can't expect those results. Selective individuals can have preoperative ERCP, and I will come with that question of how to do that. Or we can do lap chole, intraoperative cholangiogram, and then do a lap chole CBD exploration. We can also do lap cholecystectomy with intraoperative cholangiogram and perform a post-operative ERCP. There's only one underlying factor which I think all of us would agree, that you have finished a cholecystectomy maybe a month ago, 6 months ago, 2 years, 5 years down the line, patient comes with a stone in the bile duct. These patients are best treated by endoscopy and not by a laparoscopic common bile duct exploration. So laparoscopic alone with expected management, as I've already said, unacceptable at present because it may lead to pancreatitis and other problems. All patients having preoperative ERCP or MRCP, not cost effective. ERCP has complications, and therefore for a 10 to 15% yield, it seems to be overdoing the procedures. Selective preoperative ERCP. Now, this is the technique that is most widely followed across the globe. So though lap common bile duct exploration has come in, it is still not taken up. I would say that 95% in excess of stones are still treated by this method, where you do preoperative strict risk stratification, basing patients into low, intermediate, and high risk groups. Low risk patients will have less than 5% chance of common bile duct stones. High risk patients will have a risk of more than 90% and therefore can have an ERCP. So the factors that include to make these risk factors include Preoperative presence of cholangitis, almost 100% it indicates that there's a CVD stone. Preoperative jaundice in the form of increased bilirubin, especially if it is more than 3 milligrams, almost certainly indicates that there's some obstruction. Increased alkaline phosphatase, if it is more than 3 times the upper limit of normal, or the gamma GTP, if it is more than 3 times the upper limit of normal, yes, it is highly significant. A dilated CVD on ultrasound or a dilated CVD on CVD stone is found on ultrasound, that is important. So these are the important things. And in modern last 10 years now, if there is an MRCP evidence of dilatation or stones, that would be an important extra criterion for knowing that there is a CVD stone. So based on risk stratification, what do we do? Patients who have a high risk will have, today's world in majority of centers, and I will discuss if there's a role for lab CVD exploration there, will have preoperative ERCP and a sphincterotomy and clearance of the stones, and then go on to a lap cholecystectomy. Low risk patients, that means less than 5% chance of a CVD stone being present, LFT is normal, duct is not dilated on ultrasound or MRCP, then there is no reason to do an ERCP preoperatively. We can do lap chole. If the patient ever develops the symptoms of a stone, we can do an ERCP. And a medium risk, that means bilirubin is probably normal, there's no cholangitis, but the alkaline phosphatase and gamma GTP may be raised 2 times, 2.5 times the normal value, not more than 3 times. So these are known as intermediate risk patients who may in some aspects have a stone, or they might have passed out a stone, and they can either have an MRCP, they can have an intraoperative cholangiogram, or they can have an endoscopic ultrasound in the modern era, and all of these are equally acceptable results. So we looked at our own figures from 94 to 2001. 518 patients out of 2,385 patients undergoing lap chole in that 7-year period who had risk features suggesting that there are stones in the CBD. When we looked at these patients, what we realized was that we had done a lot of normal ERCPs, 21%, 104 out of 518 patients had a normal ERCP, which means that this was 1 out of every 5 patients, the ERCP was unnecessarily. The good factor was that only 3 of the patients out of this group came back for a post-op ERCP because they had missed a stone. So stratifying patients by preoperative risk factors is a very good strategy to rule out a CVD stone. But they will have a significant percentage of negative ERCPs, which is not good, because even if 1 or 2 of these negative ERCPs develops a pancreatitis or a bleeding or a perforation, that can mess up your entire practice. So today we have this new option of laparoscopic common bile duct exploration. So we can have that patients with high risk or medium risk. We can have laparoscopic cholecystectomy, intraoperative cholangiogram, and if there is a stone seen, maybe we can do laparoscopic common bile duct exploration. Low risk patients have only laparoscopic cholecystectomy. There are certain units which do policy of IOC routinely, and in some countries in the world like Australia, Scandinavia, it is mandatory that every cholecystectomy must have an IOC, and it must be documented on the case with a photograph and a radiograph, because of the incidence of bile duct injury. And there was some evidence that IOC can reduce the incidence of bile duct injury, though I personally don't agree with that thing. I think it recognizes the injury. So why do laparoscopic common bile duct exploration? What is the rationale? Well, the first rationale is that it's a one-stage procedure. So today, in many major centers, patient will go, if he has gallstones with CVD stones, he will first go to the medical gastroenterologist or to the therapeutic endoscopist, have an ERCP, have a stent placed, come back to the surgical department for lap chole, get a date, come back for admission, have a lap chole, and then go back to the medical gastroenterologist for removal of the stent. So It takes time, it's costly. By doing lab common bile duct exploration on the table, we can do a one-stage procedure. We can avoid a sphincterotomy. The advantage of avoiding a sphincterotomy is that there is less chance of recurrent stones, because once you have divided the sphincter, infection keeps going up the bile duct and you can get recurrent CBD stones. Percentages vary from 2 to 16% in literature. There is apparently a less chance of biliary malignancies if you have not done an endoscopic sphincterotomy. The Japanese have followed up their sphincterotomies very closely and find a slightly higher incidence of bile duct cancer and intrahepatic cholangiocarcinomas. Obviously, if you don't do a sphincterotomy, you don't get pancreatitis. That is a very big advantage. Those of you who have practiced in centers where you've had acute pancreatitis following ERCP know that once in a while even patients die of it. And it can be a very severe pancreatitis. Finally, perhaps the most important reason surgeons have always been dreaming of doing this in large numbers is it brings the common bile duct stones back under the surgeon's umbrella. It was lost for some time. It had gone away to the medical gastroenterologist. Now we can bring it. But to say a procedure is good, you must have good results. So when we look at the early series of lab common bile duct explorations, we find that clearance rate at the first surgery was 90%. Retained stones varied from 0 to 19 on an average of about 5%. There was a conversion to open common bile duct exploration of to 4%, about 1 to 20%. There were complications, mainly postoperative bile leak from the choledochotomy site. And because of that leak and sepsis, there was the occasional mortality, and the overall figures were about 1%, reasonably good figures. So there were a number of trials which compared laparoscopic common bile duct exploration versus endoscopic sphincterotomy in the early part of the laparoscopic experience in the late 90s and early 2000s. 3 studies which looked at mortality, which was not significantly different, morbidity was not significantly different, pancreatitis was not seen with lab common bile duct exploration, but varied from 4 to 19% on what criteria you used. But the severe acute pancreatitis requiring admission complications would be about 4 to 5%. The success of both procedures was about 83 to 90% or 100%. But open laparoscopy had conversion to open surgery in a significant percentage, depending on the study, from 2 to 20%. And I suppose that varies from the skill and the equipment available to the surgeon. Because if you don't have all the equipment, you are more likely to convert. But then let us see what happened down the line. And this is a meta-analysis done in 2018, published in Annals of Surgery, very prestigious journal. Has the highest impact factor of all surgical journals from China, and they looked at online databases from 13 studies from 2006 to 2017, and they compared laparoscopic common bile duct exploration with lap chole versus preoperative EST and lap chole. The number of patients in both groups were roughly equal, 872 versus 885. And when you look at the CBD clearance rate, approximately the same for both the procedures. Perioperative complications slightly less for laparoscopic common bile duct exploration. Retained stone rates, surprisingly in this study, was much less in the lap common bile duct exploration. And when you look at the operative time for cholecystectomy with ERCP and you join the 2 sites, you actually find that the shorter time for the common bile duct exploration and lap chole. Hospital stay for the 2 procedures put together is significantly less for lap common bile duct exploration. And total charges were significantly lower in laparoscopic common bile duct exploration because ERCP is an expensive procedure in most hospitals across the globe, and it adds significantly to the cost. They concluded that lap common bile duct exploration and lap chole is superior to preoperative sphincterotomy and laparoscopic cholecystectomy, both in short-term efficacy, long-term efficacy, and in cost-wise. But in surgical endoscopy in 2019, another meta-analysis is published, which is published again from China, where they compare laparoscopic common bile duct expression in cholecystectomy versus ERCP and lap chole for. And in this, with about 1,545 patients, almost the same number of patients as the previous group, this group almost seemed to reverse the results. Significantly higher CBD stone clearance rate for ERCP and lap chole. Post-op bile duct leakage was found for pre-op ERCP and lap chole was less than for lap common bile duct expression and lap chole, which is acceptable because when you open the bile duct, you have a higher chance of a leakage. However, a significantly higher rate of pancreatitis was found in the ERCP group. In overall operative stay, laparoscopic common bile duct expression and lap chole was superior. However, their conclusion was that pre-op ERCP and lap chole is associated with a higher CBD stone clearance, lower bile duct leakage, and higher rate of pancreatitis. So, but it helps to shorten. So we had confusing pictures. But one thing of both the studies is that in a large number of patients, when they looked at it, clearance rates of bile duct and overall significant mortality was very less with the laparoscopic common bile duct exploration. This patient looked at transcystic versus transductal when it was feasible, and they said that transcystic is associated with a lower cost, better pain scores, lower complication, and shorter hospital stay. Our own problem with transcystic has been that for the transcystic, you need a very fine choledocoscope. You can't do it with a ureteroscope or any other scopes which people use for common bile duct exploration because the cystic duct is much smaller. And you may have to use balloons to enlarge the cystic duct before the scope grows. These fine scopes are very fragile and they break easily. When we began our laparoscopic exploration in 1997, I actually had purchased in the hospital a transcystic scope from Carl Stores, which was very thin. And on the third use, it went, and that had cost us about 7 lakhs. And to repair it, they said, this is not repairable. You'll have to replace the whole scope, which will cost you exactly the same amount. So I have, after that, never been doing transcystic exploration because I felt the cost of the scope is not worth in India. Whereas abroad, they don't mind $20,000 if it will save them overall time, and in even 3 or 4 patients, they don't mind the cost. India is not like that. So I have not now, for the last 23, 24 years, done any transcystic cases. Always I've been doing only transductal cases. Please remember that laparoscopic common bile duct exploration is not an easy operation. It is technically challenging. You need to have intracorporeal suturing skills. It requires either the availability of an IOC, which should be dynamic, which means that as you do it, you should be able to see. You can't put dye, shoot, and then wait for the films and do it. No, you have to have fluoroscopy. So either you need a C-arm or a X-ray machine built to the theater, like they have in many foreign countries, or you should have a choledocoscope, which can be passed in, which is usually slightly bigger than the normal choledocoscopes. But there is one fundamental caveat, and you must remember this. If you take no other message from my talk, this message you must take. You cannot do laparoscopic common bile duct exploration on an undilated duct. So you need a minimum of 8 millimeters, preferably a 1 centimeter duct, before you venture onto laparoscopic common bile duct exploration. If you take up smaller ducts, you will end up with strictures of the bile duct in the long run, and they will be difficult problems to manage. So you must know that patients who don't have dilated ducts are not good candidates for laparoscopic common bile duct exploration, in my opinion, and it is better to avoid it in these patients and to let the ERCP do the job, because even in a small duct, it is equally effective. Because you have to do a cholecystoscopy, it implies that you have a video cholecystoscope or a second camera which you can put on your fiber optic cholecystoscope, a monitor, and you know how to use baskets and balloons to clear the duct. There are some people who advise that you do lap chole, you do IOC. If there is a stone, you do a post-operative ERCP. Yes, it's a reasonable approach. They've shown fairly good results, but my problem is that once in every 20 or so patients, you will fail to do a ERCP. What then do you do? Will you go back to doing laparoscopy or surgery after some time, which is difficult? So I think that the ERCP, if it has to be done, should be done pre-operatively, post-op, or you do it intra-op, so that if you fail, you have some other alternative to do it on the table. So do an IOC if you think there is, get the scope in and do it. If you rely on a medical gastroenterologist, they will be reluctant to come to the theater, change the clothes and theirs. Therefore, what is the answer? Surgeons must do ERCP. At least one of the team should be, or two of the team should be trained, and they can simply ask for the scope and do the procedure. That's what we do in our theaters. We are all trained in ERCP, and any one of our surgeons just performs the procedure in the emergency if the IOC shows. So our protocol till EUS was available to us, that is up to 2007 when we got EUS. High risk group, pre-op ERCP with stone extraction, do the lap chole after 24 to 48 hours. Medium risk, we do an IOC, laparoscopic common bile duct expression if the duct is larger than 1 centimeter. And if they are large stones, 1.5 centimeters or bigger, rather than using expensive lithotripters and other things, we would do a ERCP, place a nasobiliary drain, and do a laparoscopic common bile duct exploration. Why avoid using sphincterotomy to break these stones and try to clear it? The reason is that sphincterotomes, the mechanical sphincterotomes, cost about 30 to 40,000 rupees each, and they usually don't last for more than 2 cases. So we have to, the moment there is a mechanical lithotripsy to be used to the ERCP charge, we have to add 20,000 rupees. You can't do lithotripsy very easily under sedation. You may have to give general anesthesia to do it. Therefore, we say that it's much easier if there's a big stone, there's a big duct, we can just open the duct and take it out. If some people have the stones, definite scopes available, they can do transcystic removal. Otherwise, we prefer the direct choledochotomy. Therefore, our ducts must be slightly larger and we need choledocoscopy. So when we looked at our treatment results from 94 to 2001, we had 15% residual stones. Most of them were cleared by repeat ERCP. And about 5.7% we had missed in Mirizi syndrome on the ERCP, probably because we were not that experienced. We did fail in a certain number of patients, 5% of patients. There was failure to cannulate. And in 9, there was either a deformed pylorus or a GJ, so the ERCP became difficult to do or not possible to do. We had complications of about 2.2%. We had post-ERCP pancreatitis in 4 patients, liver abscess in 5. And in 3 patients, when we tried to do the lithotripsy, the basket was impacted. We couldn't remove it. And then we had to go laparoscopically cut the basket. The basket was lost. But finally, we salvaged these patients. We had to convert 3 patients in the first 18 of the 52 patients in that period. 3 of the first 5 were converted. Obviously, when you have less experience, you're just starting, you're less confident of completing it, and you easily convert. And of course, in 15 patients, for reasons of anatomy, previous surgery, we did only open common bile duct explorations. So some patients after lap chole and ERCP developed incisional hernia, port site infections, liver abscesses, bile leaks, including most of them were in the CBD exploration groups. We had a morbidity of 12% with ARF in 8 patients out of 265, ARDS in 6, and in the 3 out of the 6 patients in the ARDS group died in this first series of patients. In 2005, we relooked at the figures from 2001 to 2005 to see if we had improved after having now some experience. We had done 617 ERCPs. We had a significant number of CBD But you see that the 21% had not come down. It was still 23%. So we were still having a high rate of negative ERCPs. This was something that we didn't like. We had a 8% rate of uh, failed ERCPs. We did lab CBD expression in 40 of these patients. And some patients refuse to have further treatment because once it becomes more expensive, they don't want. But the only good news was that we had no pancreatitis and no mortality in this group of 671 patients subsequent to the first group. So we had done almost 3 times the number of patients. But while we lost 3 patients in the first group, in this group, we didn't lose any patient. We did lab chole after ERCP clearance in 206. The reason is that we get a lot of patients referred to us by surgeons who say, you do the ERCP and send us back the patient for the surgery. We are happy to do that. We send the patients back to them for the open or lab cholecystectomy, whatever they want. Majority of patients, we managed to do the cholecystectomy on the first day or second day post-operatively. Usually the next day. If it is done on a Saturday, it will be done on Monday. So some of these cases will have 2. And we had no conversions and no morbidities from the lab coding. In this, we also looked at difficult CBD stones. What are difficult CBD stones? Access is difficult. That is a GJ done for duodenal obstruction. Difficult to reach. The loops are long. ERCP fails because we can't cannulate. Stone is very large, 2 centimeters, 1.5. Multiple stones, or there's a significant stricture distal to the stones. So to look for the laparoscopy in management of difficult CBD stones, we again analyzed data for 2 years, 3 years. And when we had a suspected CBD stone, we would do an ERCP. Simple stone, we would extract by ERCP. Difficult stones, we would take the patient up for laparoscopic CBD exploration. If if they could cannulate the duct, we would leave a nasobiliary tube because it helps to identify the duct on table and also to test your closure after the procedure is done. We would do lab CBD exploration with a coldocotomy, stone extraction, coldocoscopy, and a primary closure. Because we have done the ERCP and we have placed a nasobiliary drain, we can do a primary closure. We don't need to keep a T-tube. Sometimes the ERCP has failed, we would leave a T-tube as a safety precautions. 546 ERCPs, we classified 14% of the stone as difficult CBD stones. Some majority were large stone, more than 1.5. Some were failed ERCP, stricture, difficult access. There's a demography. And after ERCP, we would put an NBD in 80% or a stent in some, and only sphincterotomy was in less number of patients. We did primary closure in 19 patients. Some of them were interrupted. Most of them, because the ducts were large, were continuous sutures. We put only 2 T-tubes in this group of patients. Average operating time was 149 minutes. It was more in the beginning, and now it has become considerably faster. We had no conversions. One had to be hand assisted because it was very obese. The average stone size was 1.9 centimeters. Number of stones were about 1.6. No morbidity. The patient who had a hand-assisted coldocostomy, morbidly obese, had post-operative MI on the 5th day and died. Hospital stay was about 8.5 days. Not short because these are major operations and our patients are reluctant to go home. When the ERCP failed, we managed to do one case with transcystic stone removal where the cystic duct was very big, so we could put our standard coldocoscope through the cystic duct. And in 4 patients, we did a coldocotomy with a T-tube and a coldocoduodenostomy in 1. The failed ERCPs, when you're trying to do the lab CBD exploration, mean operating time is about 3 hours. It can go up to 6 hours. And the hospital stay was quite long. One patient stayed for 63 days after bile repeat ERCPs, and he went home. And he had a significant morbidity, and he subsided after multiple sittings of ERCP with stents, and then also a GJ because the duodenum was stenosed. Mortality was nil. If there was a stricture, we did a coldocoduodenostomy in 1, and we managed to manage the rest with just a T-tube. Again, the operating time is about 2 hours. The stricture is less because you know straight away you are not going to do anything below. You are going to do a bypass or put a T-tube and come out. Therefore, we found that it is quite effective in the management of bile duct stones. We rediscovered the nasobiliary drain. So unlike a stent, the advantage is it decompresses. It helps you to identify. You can inject methylene blue or water to dilate the duct. Now we inject indocyanine green, and with the new cameras for the last 4 years, we can see the bile duct very nicely if it is not visible by using indocyanine green. The nasobiliary trim is a good guidance for coldoscopy. And after you close the intraoperative bile duct opening, you can inject dye and see that there is no leak. Post-operative, next day we do a dye study for any residual stones or a leak, and if there is none, we can just remove it. So patient doesn't have to come back for an ERCP. It's much cheaper than a stent, and we can put ICG to this thing. In 2007, we took a major step forward. We added endoscopic ultrasound in our armamentarium. So we first standardized EUS by performing ERCP or IOC and compared the first, I think, 150 odd cases to the IOC and ERCP. And we learned that after the learning curve, EUS started to show that there were no stones where we had previous indications like the high risk factors. So we made a protocol after we had validated EUS, having done ERCP or IOC, that if EUS was negative, ERCP will not be done. And in the study in 2010, 3 years after the availability of our ERCP, EUS, when we had standardized the procedure, we showed that the negative ERCP had come down to 5% from 23%. That's a tremendous achievement, that about 18% of patients you no longer do ERCP. And endoscopic ultrasound, no stones in the CBD, they have high risk factors, but you just do a lab correlate. Tremendous advantage. I think it's a great boon, EUS, in the field of gastroenterology. So we looked at patients from 2012 to 2017 when we had a very protocolized workup. All these patients now have a pre-op ERCP amylase, pre-ERCP amylase and lipase to make sure that there's no rise before the procedure. What we found was when we started doing this routinely, patients would come in with gallstones, have no alteration in liver function, but amylase and lipase will be in the 800,000, even more than 1,000, suggesting that they have had a subclinical pancreatitis, in which case we would wisely wait before we did anything so that they would improve and then we would take up. And this is about 5.5 years. We did 775 patients. We had total number of ERCPs was 1,592. ERCP for CBD stones was 728. So and surgical explorations were 102. And there's the age distribution, sex, prior interventions, symptomatology. Most patients had pain, significant percentage had jaundice, fever or cholangitis. The bilirubin or the OTPT or GGT alkaline phosphorus is raised in about 42%, and 638 were successful. We had 90 failures still. So one of the reasons is that we now had 3 surgeons doing it, a number of gastroenterologists coming and going. So we had about 6 consultant gastroenterologists who came, learned, and then they did. So we had a little more failures, but which is acceptable. 524 were straightforward, 114 were classified as difficult, 95 patients were having cholangitis. Difficult ones, we dilated strictures, we used lithotripters like trapezoid or the Olympus lithotripter, or we did 2-stage ERCP. But 90 still failed due to a variety of things like altered anatomy, impacted stone, incomplete clearance. And when we had fistula like cholecystocolic demonstrated on ERCP, we went straight for surgery because you have to divide the fistula and close it, which we did laparoscopically. Cholecystoduodenal, we have done that laparoscopically. Of course, clearing the CBD stones with ERCP. Choledochoduodenostomy, if they were already there, fistula, we would leave that alone and clear the bile duct. If there was a Mirizi, then of course, large percentage will fail with ERCP. But majority of varices we would now do laparoscopically using a flap of the gallbladder to close the bile duct. And majority of patients we had ERCP, stone removal, lap cholecystectomy and discharge on day 2, 338, more than about a half, 50%. So single admission, complete clearance with a variety of procedures. There were 67 laparoscopic procedures out of the 102 surgical exploration. 25 were primarily open because of difficulties and 10 conversions. And we did lap CVD exploration, cholecystectomy, hepatococcygeostomy, colorectal cyst, various types of operations. Complications of ERCP, we definitely improved. Now we had 2 melena, which was probably delayed bleeding, mild elevation of serum amylase in one patient who had pain and tested the amylase had risen from the pre-performance, no clinical pancreatitis, perforation or impacted baskets. So definitely we had sided that learning curve because the scopes and baskets and guide wires had become much better in the 20 years that we started. And this, again, we had no mortality. So this was sort of now the, it's a very busy slide, but what it tells you short is that if the LFT and ultrasound are normal lap chole, if the patient is cholangitis or sick, ERCP, even in the emergency, if it's a success, put a stent or an NBD, wait till they improve and then do the lap chole or send them home and ask them to come if they've had ARF or ARDS. The US is normal. We will not do any ERCP, even if there are abnormal LFT or ultrasound report. Even we have had patients who have had MRCP report of CVD stone. US prior to ERCP shows no stones. We don't do an ERCP. We say no, unless MRCP and LFT are abnormal. And in which case, most of the studies ERCP done are still negative. And that is one of the reasons why we still have a 5% negative ERCP, because we have patients who have got relatives who are doctors and they say that LFT is abnormal, MRCP is abnormal. Why do you want to rely on US? Do the ERCP. And if they're symptomatic, it's almost the same. And once we have done, put a stent, we remove it at 6 weeks, but we try to avoid a stent in the majority by putting nasobiliary drain, so they don't have to come back. And many of these patients come from 300, 350 kilometers away, and we don't want to subject them to a repeat visit as far as possible. This is just a video to show you laparoscopic common bile duct exploration. This is a patient with a large stone. As you can see, you can feel the stone. I can show you the stone. It's quite a large stone. It's a very dilated duct. That's almost 2 centimeters. Big stone. I'm actually making a horizontal choroidicotomy in this patient. So people may wonder, is it wise to do horizontal? We already been taught that you should do a vertical cholangio. It's such a dilated duct, I think it's okay. The reason we are doing this is that if you have any doubt as to whether there is a problem at the lower end, we may then end up doing a choroidicoduodenostomy easily with this by doing a horizontal a duodenal incision and doing a side-to-side anastomosis. So here you see we have put in an NBD because we found the big stone, and we just opening the duct, and you can see that the stone is already exposed there, and we do enlarge, and we know that at this lateral end you will get some large vessels, especially when the duct is big. So we open it with the harmonic scalpel or with a thunderbeat when we come to the lateral edges. Then to remove the stone, sometimes you have to just manipulate the NBD out, because otherwise you can't remove it easily, the stone. Then you leave it and you can always replace it. And then you see this big stone that is coming out. And actually, this video is not edited much. This is almost the normal speed of the operation at which it is done. So it's quite fast. It's not that it takes a long time, especially when you know beforehand you have one large stone. And so we deliver that stone, then we clean it up, and we do some irrigation to make sure that the dirt has come out from both top and bottom. Huge duct. You can see the intrahepatic radicals are also dilated. You could see the opening of the cystic duct. We put in an extra port to comfortably place the flexible choridocoscope. which we send to the lower end, and you will see that we can irrigate from the coldoscope. And having confirmed that there is nothing inside, no more stones, we can replace the NBD to be removed the next day. So we just replace it into the hepatic ducts, and then we do the cholecystectomy. And then I will be suturing this opening, and this suturing is done with 30 Vicryl, and I take usually a extra mucosal stitch, take it from both sides. Big duct, so you can take a good bite, so there is no problem, and then do the suturing. You can see the knotting, and then it's a continuous suture I'm using on this one. Big duct, not likely to get strictured or narrowed. You need not worry. But the biggest advantage is there will be no leak of the bile post-operatively. Bile is very fluid, and if you put interrupted stitches, they do tend to leak, and we would like to avoid that. And almost the completed suturing. And once that's completed, we can put normal saline through the NBD and test the anastomosis. Here, the cystic duct is also being sutured because it is a fairly large cystic duct. So you can see that suturing which we have done. So when you choose your patient properly, like this patient, big duct, big stone, I think the results of lab common bile duct extraction are excellent. When you try to do it on a small duct, which is not dilated, and you have stones inside, you start creating more complications. And I think that unless you have very fine scopes and you are not afraid of losing the scopes, because the government will provide it in many hospitals in England and Scandinavia and USA, which it won't do in India. Even government hospitals won't have be able to get a scope every 3 or 4 cases. I think you will find that if you incorporate a management protocol where you can do ERCP in a large number of cases and reserve the lab common bile duct exploration when it is needed, and do it competently and well when it is needed to be done, I think it's an excellent procedure. And as we have shown you from our figures, overall success rates of almost 98-99% in the management of both gallstones and CBD stones, and no morbidity, no mortality. And in the last 5 years now, we don't have bile leaks from the common ducts. We have managed to secure those because our suturing has improved, our sutures have improved. If some of you find it knotting and all difficult, you can always use a V-lock suture, the barbed suture, which is there, and you can use that to suture the gland. This is another case just to show you the that even in a difficult gallbladder, you can expose the common bile duct like we have done here. And in this case, I am opening this gallbladder, the bile duct longitudinally, because I'm fairly confident of what is happening lower down. And then this is where we do the coldoscopy after removing the stones. And so here I'm using the barbed suture. You can see the suture. You will see that it is got the barbs. So it maintains its tension, and you don't have to knot it. You have to just pull it through the loop like this from one side. So no knotting is required intraoperatively. and you can just tighten it and it will stay tight. It will not loosen up. Now, some of the problem with sutures in laparoscopy is that they keep becoming loose. Here, it won't become loose. Uh, you have to be a little more gentle with the suture because the same size as the non-barbed suture, it is much weaker because the number of notches which are cut, so the suture becomes weak. So you have to use it a little gently, but it's quite useful for suturing. And you can see here how the suturing is going on. And when you pull this tight and place it, it will stay there. You don't have to worry. So I think that's a very good suture. And if you have difficulty in suturing, there's a suture that you can, it is now freely available. There's no problem. And we come to the lower end, and once we finish that, we can then inject saline. So the whole hole has to be closed. You can see a little bit of gap there. So that's also closed nicely. And then you can put dye if you've got an nasopharyngeal tube, and you can clear it. And we're just seeing that absolutely watertight, and no need to knot. You can just pull it and leave it. It will not slip back. You don't need to knot it at all. So in conclusion, the take-home message is that laparoscopic common bile duct exploration is a feasible thing. We look at patients with symptomatic gallstones based on their ultrasound and LFT. We stratified them. Low risk group, we do only a straight laparoscopic cholecystectomy. Moderate or high risk, we do US and then ERCP. If the ERCP is successful, laparoscopy after 24 hours. We, in majority of patients, we place an NBD. Sometimes we place a stent if they have had cholangitis or multiple stones or difficult clearing. In unsuccessful ERCP, you repeat in 48 hours. If it still fails, we will do laparoscopic common bile duct exploration or open surgery if the patient has got something like a colorectal cyst or something, and we don't want to do laparoscopy because the patient is not, or has got comorbidities like myocardial problems or COPD. We will do an open surgery under maybe epidural anesthesia and sedation. Lap CBD exploration is not an easy operation. I find a lot of lap surgeons are very enthusiastic about it, but they do a bad job. I think you should choose your patients. Have a wide bile duct, big stones, limited number of stones. I think you can get very good results. Sometimes we have sat for 2-3 hours clearing 50, 70 stones from the bile duct in patients with recurrent pyogenic cholangitis, and then doing a side-to-side anastomosis. So it is worth it, but it can be tiring, and you sometimes wonder if it's worth the effort, because at the end of it, in India at least, the patients don't pay you more. They'll pay you the same whether you do a 6-hour lap surgery or a 1-hour open surgery. Thank you very much for your hearing. I'm open for any questions if you have.
Yes, sir. Sir.
Thank you, sir.
Sir, I just want to ask a question, if you allow me, Dr.
Oh,
Bala.
of course. Anybody can ask, no problem.
Yeah, I'm Dr. Rajkumar from Jaipur. Sir, I'm doing a lot of the lab CBD. I just want to ask question about the cholecystocoldocor fistula type 3 especially, and to some extent about type 2 also. So in those cases when we are doing lab, and I've seen in in follow-up period some kind of narrowing at the site of suturing. So it should be done lab.
If you have a duct which is not very big, then I would suggest that it be done by ERCP, put a stent. Then you do a lapochole, and then you divide the fistula. If you do a lapochole, and if there is a fistula and you just put a stent, I actually won't even divide the fistula, because the fistula itself is not a problem. The stone has formed not because of the fistula. The fistula is formed because of the stone, and there was an infection. Once you remove that, it will be all right. So I actually do cholecystodiurnal. I will divide, but choledocodiurnal fistulas, I will just leave them around alone, and I will just put a stent in the CVD to make sure that the CBD is all right. If it's all right, many of the times this fistula will close later on its own. If it's a cholecystoduodenal or cholecystocolic, you will have to divide the fistula and then you have to close, but the duct won't be narrowed because your suturing is not on the duct. Your suturing on the duct only will narrow it. So if the duct is narrow, I would advise you that don't suture, or if you have to suture, then if you make a longitudinal opening, suture it horizontally, like we do a pyloroplasty. So the cut in one direction and suture in the other direction, it will widen the opening so that even if it contracts, it will still remain fairly wide.
In those cases, when we are opening CBD in the direction of the cystic duct, in cases of cholecystocolic along the stone, then it is oblique. Then it is oblique always.
Yeah. So what I do is that you are talking of a thing like a Mirizi. You are talking of a Mirizi syndrome then.
Yeah, type 3, you can say.
Yeah. So what I would do is that I would leave a bit of the gallbladder when I cut it. Then I fold the gallbladder onto the bile duct as a patch and close it so it doesn't narrow the duct.
Yeah. But even then, it has been seen in post-op period in few cases that there is some kind of narrowing is always there.
Yeah, so if there is narrowing and it doesn't cause any alteration in liver function, and it is still of sufficient size, which means the normal bile duct is about 5 to 6 millimeters. So if your opening is still 5 to 6 millimeters and it is not causing any obstruction, I think you are safe. If it is causing obstruction, you may need to stent these patients for a longer period. So you may have to put 2 or 3 stents and keep the area open for say 1 year to 2 years and change the stents every 6 months and or add a stent every 6 months.
Okay. So stent should be there for a longer period.
Yeah, but one stent won't be enough. You will have to put
2 or 3
2 or 3 at the first attempt and then add another stent after 6 months. So you keep about 4 stents across so the width of the stricture will stabilize to the combined width of about 4 stents over a period of a year. And that is what is the Costa Magna type of treatment of biliary strictures.
Okay, sir. Thank you so much. Thank you.
Thank you, sir. Sir, one question. Can we use ureteroscope instead of bronchoscope?
Yeah, ureteroscope I told already. Yes, some people use it. I don't personally use it because I prefer the flexible coldocoscope, but you can use a ureteroscope also, yes.
And sir, one question from UG student. What is nasobiliary?
See, nasobiliary tube is a long tube that you put through the ERCP scope into the bile duct, and it is a curved tube and it will stay on top. Yeah, like the tube you saw during the ERCP. It is placed into the hepatic duct. It doesn't slip out. It comes out of the nose and it is fixed with a stitch to the nose. And we keep it during the surgery, and after about 1 day we remove it. So it stays for a total of about 48 hours. The advantage is that during surgery, the anatomy is very difficult. You can inject some dye or a methylene blue through that and then see as the duct dilates, where is the duct. If you have a stent, you can't inject anything through that because it is not visible outside.
Thank you, sir.
Sir, one more question. Just
yeah.
Sir. So in case of multiple CVD stone with a CVD diameter of more than 10, maybe around 12 or 13, then also you would prefer to do by lab this CVD exploration, or would you prefer to do choledochoduodenostomy?
No, I don't like to do choledochoduodenostomy unless there is a stricture below. If the bile duct is normal, I will clear all the stones and that's it. Most of them settle down. Unless this is a primary CBD stone, because the cholecystectomy is done 10 years ago, now so many stones are formed, so you think they are primary stones. In that case, you may require some drainage. But if you can do a wide ERCP, that is as good as a choledochoduodenostomy. It's a side-to-side choledochoduodenostomy. The sphincterotomy is a side-to-side choledochoduodenostomy.
Dr. Ramesh, Dr. Babel is here.
Yeah.
Hello. I want to ask one question. There is an impacted stone at the lower end of the CVD.
Yeah.
Impacted stone at the lower end of the CVD. What do you prefer? Do you go for the CVD exploration, laparoscopic, or you first ask them for go for ERCP and then they left polymer like that?
So most of the time, if it is impacted, ERCP, they will not be able to disimpact it. If they can disimpact it and break it, it's okay. But most of the time, they can't. Then what we do is we do lab CBD exploration. And even there, it is difficult to disimpact. Then we use a laser lithotripter. We borrow it from our urology theater and we use it through the coldoscope. And we actually blast the stone into little pieces till the whole thing breaks. And then we can just take it out. We have done that quite often when there's an impacted stone. It's not easy, but it can be done. And we have done it. You must have all the right instruments, including the laser lithotripter, which is actually the best instrument for that because it goes easily and it sits and it very fast it breaks the stone. We used to have electrohydraulic, but now they no longer make the probes for electrohydraulic, so we had to abandon it. So now we have gone to laser.
Sir, good evening. Myself,
Yeah.
Dr. Gupta. Sir, I want to ask one question. Sir, you
Yes.
see ERCP in the theater, but it's not in the every institute.
Yeah, I know that. So that's what I said. If you don't have it, then this question of doing post-op ERCP doesn't arise because what happens if it fails? So either you should be, it should be a very dilated duct which you can then do CBD exploration, or else you do a pre-operative ERCP. Fix
So
it
what
with
is the
them.
ideal time after failed ERCP for the laparoscopic CBD exploration?
We do it the next day also.
Oh.
No, as long as next day there is no evidence of pancreatitis or bleeding, we just do it the next day.
Okay. So my second question is, what are the prerequisites for the primary closure, and we want to go for the stenting or the T2 drainage in CBD after exploration?
See, if you got stenting, that means that the lower end is fine. You have done, you've cleared the lower end. In which case you can do a primary closure, no problem. Problem is if you have not put a stent, if you don't know, in which case you must have a coldoscope to make sure that you don't have any residual stone, and you look at the sphincter and make sure the sphincter looks all right. It is opening and closing, and then you can then do primary closure. But you must be reasonably sure that you have removed all the stones. If you have not, then always safer to put a T-tube and come out.
Thank you, sir.
Thank you, sir.
Putting a T-tube is safety in surgery. It is like converting in a lap chole. It's for safety for the patient. It is not a failure of surgery.
Okay, sir.
Thank you, sir, for
Yeah,
your
thank you.
comprehensive talk on the CBD exploration and accepting our invitation. Thank you, sir.
Thank you, Bhamar. Thank you. Good night.
Now, next lecture in today's webinar series is Recent Advances in Management of Benign Breast Disease, and speaker is Professor Diptender K. Sarkar, sir, Consultant Breast Endocrine and Surgical Oncology at Institute of Postgraduate Management, Postgraduate Medical Education and Research, and SSKM Hospital, Kolkata. So now over to Sarkar, sir.
Thank you. Thank you. Good evening. Good evening, Bhamar.
Thank you, sir. Thank you.
And I hope I am visible and audible, isn't it?
Yes, sir.
Okay. So at the outset, I'd like to thank the Association of Surgeons of India Rajasthan chapter, and particularly to Professor Shalu Gupta, the president of the chairman of the association, and my dear friend and brother, Dr. Bauer, with whom we have shared so many wonderful experiences during the ASICON and as a governing council member for so many years. Thank you, Bauer, for giving me the opportunity to be present with your wonderful effort. I hope to take you through a very interesting topic of benign breast disease. Now, what has happened over the last 5 decades is because breast cancer had been the Amitabh Bachchan of the industry, people have forgotten and forgiven the Amrish Puris. But believe me, benign breast disease comprises of the major component of breast as a specialty. And when we sit in our clinic every day, over 90% of the patients have benign breast disease. And most of the time, we are left with the education that is being given to us by medical representative, and we are giving any new medicine that is found on the corner of the street. Now, the picture that you see on the slide represents all three religions with its traditional form of medicine. And you may be tempted to believe why these three forms of traditional medicine could not get into the mainstream. The only reason is that our form of medicine over years have been able to generate one single thing, which is called the evidence. And these guys who are on the right side of the slide did not ever try to put it down on a glossy paper, and therefore they are left with nothing but the street corners, whereas we are doing webinars on this particular subject. So evidence speak, and I am going to take you through something in the field of benign breast disease. I am going to take you to two parts. One is what is the current consensus, and I chose one important topic in the field of recent advances, which I will come on in the second part of the discussion, and I call it the idiopathic granulomatous mastitis. As a preamble to the talk, it is necessary to once again start that triple assessment forms the pillar of breast evaluation, and of which, as you see here, the clinical breast examination, radiology, and core biopsy, of which the third component have gradually gone into oblivion. So we have left with firmly and on a robust basis of shifting to core biopsy at present. And FNAs will be something to tell to our grandchildren in another 2 years' time. So when we categorize a lesion, we would categorize it like the way it has been written here. Number one, it's clinically benign, it's radiologically BIDATs 1 to 3, and FNAs will disappear, and core biopsy, which is the most objective form, and we are going to tell it is a core biopsy 5 lesion or a 3 lesion or a 2 lesion. What I am going to do first is introduce you to postgraduates, and I thought there were undergraduate students who were also part of this wonderful endeavor. I'm going to take you to a new kid on the block that's called elastography. Now, what is elastography? We all know that when it's a balloon which is filled with water and we press it, what happens is that the balloon dips, and once we release, once again it comes back. So traditionally, what should happen is a benign lesion, when we push by an ultrasound probe, it should go down, become compressible, and when we release the pressure, it should come back to the same position. And therefore, it is a compressible and an elastic structure. But when it comes to a malignancy, as we see here, you see the desmoplastic reaction, which actually envelopes a benign a central core of a malignant lesion. That makes it very tight and non-compressible. So in these group of patients, if we do an elastography, you will find a very hard lesion, non-compressible lesion, and that is the basis of what we call an elastography. And there are two forms, the strain form and the shear forms. I'm not going to go into the details of that, but what I would like the young trainees to look at this is, look at this. Now you see that once you put it on a color code, if it comes out to be red, that means it's a very rigid lesion. Though, of course, the color red is the choice of the company or or the person who is doing that. But if you find it red, which is a sign of danger, and if it's a rigid one, it colors red. Whereas if it is a non-rigid one, it is likely to be blue. And here you see, once we do it, it also mentions in kilopascal what is the amount of rigidity. So higher is the kilopascal and higher is the red coloration of the lesion is likely to be more malignant, and lower is the kPa and bluer is the lesion, it is likely to be a benign lesion. And therefore, this is the classification. I'm not going into the details of that, but just like the BI-RAD lesions, it can have 5 different ways of classifying ultrasound elastography. And this is how it basically is, based on a principle of whether it is deformable or it is stiff. And if you find that the score 5 lesion, it is going to be very stiff and non-deformable lesion. That's what is a malignancy. But believe me, if you try to use this tool, you should not be using it generally. I mean, it should be restricted mostly to score 2 and score 3 lesions like the one you have here. I mean, if you know clear-cut it's malignancy, there is no point in using this tool. It is only for those lesions which are borderline and you do not know whether it's a distinctly benign or a distinctly malignant lesion. I can assure you with a good amount of certainty, and elastography can be a problem-solving tool. I will go to the second chapter, which is the current consensus. And most of the times we do have confusions on this. Now, patient comes to you with nodularity, you don't know what to do, whether it should be excised or it should not be excised. Quite often you end up in excising an adenosis and fall into an embarrassment. Can we offer non-operative management? What's the objective guideline? How should we evaluate nipple discharge? And finally, when to intervene in case of a breast cyst. Now, coming to the core area 1, that is nodularity. Should it be excised? Now, this is a classical patient of 37 years female who had presented with a nodularity in the breast. We did an ultrasound, and the ultrasound showed this BI-RAD 3 lesion. A core biopsy was done, which showed epitheliosis with proliferation. The question comes is, are we going to excise this lesion? So the answer to the question, now look at, this was our initial data which we got published. It goes back almost 1.5 decades back when we were struggling with FNAs only. And we could come out with a conclusion that if you're doing an FNA in such lesions, or a core biopsy for that matter, if you find it's a normal, or if you find it's a non-proliferative lesion, then you should leave it alone. That means if you find a fibroadenosis with a nodularity and you do a core biopsy, you find it to be a non-proliferative lesion without any epitheliosis, without any evidence of papillomatosis, you should not be operating. On the contrary, if you find it's a proliferative lesion, or you find definite evidences of RTPR. These are the 2 groups of patients in which, even if it's a diffuse nodularity with a prominent nodule at a particular position, you should be offering the patient surgery. And as you see, there is a possibility almost 19% of the atypical ductal hyperplasia harboring within itself malignancy ought to proceed into malignancy later on in the course of the life. So this is the guideline. As you see, if it's a C3 lesion, then you should be offering the patient surgery. A non-proliferative lesion, you should offer them just observation. And if it's a definitely malignant lesion, of course, surgery becomes the only choice. Coming to the second core area, can we offer non-operative treatment to fibroadenomas? And this is possibly a very big debate for a very simple disease which we see every day. Now, this is a 22 years female who comes with a firm 2 centimeter lobulated lump, and in the ultrasound it's a BI-RAD 2 lesion. A core biopsy shows it to be fibroadenoma. Now, look carefully at this lesion. Now, again, the trainees must look into this and observe that this is a distinctly benign lesion because the anterior-posterior diameter is less than the transverse diameter. You look carefully, there is a halo around it. So this is a distinctly benign lesion in ultrasound, no doubt about this. Now this is it's another patient, but you look at this. This is again a very smooth lesion. And again, this smooth lesion corroborates to a finding that this is possibly a benign lesion. Now look carefully what is going to happen if you do an ultrasound of this lesion. Now look carefully, what's the difference? Both of them are smooth, but in this you find a small area of cleft. So if you find an intralesional cleft that you see in an ultrasound here, you are actually dealing with a phylloid tumor. So therefore, the question of observing such fibroadenomas does not arise. Of course, you are going to do a core biopsy after that to confirm. The question comes, and which I am being asked very commonly, whether you should do a core biopsy bluntly, or at times you send it directly to a radiologist for an image guided core biopsy. Then if you choose to do it on your own, it's fine. I mean, in the West, if you have a true one-stop clinic, then it's fine. But most of us who are working in a private clinic, and if you find a patient, then you have to send the patient for an ultrasound on another date when the radiologists come, or from the OPD to the radiologist center, and then come back. So what we follow is that if on ultrasound you find that the lesion is clear-cut solid, then I would go for a core biopsy in my clinic only. But if you find the lesion is complex, that is, there are areas of solid lesion and liquid lesion, then the chances of false negativity is high. And these are the group of patients where an ultrasound guided core biopsy has to be done. So the bottom line is, if you are doing an ultrasound guided core biopsy, it has to be a complex lesion, a solid homogeneous lesion which is palpable. You can go ahead with a core biopsy without any problem. So the criteria is very clear. Internationally, it's fixed that the size of the lesion less than 3 centimeter with multiple or the patient has multiple sub-centimeter bilaterals to lesion, age of the patient less than 30 years, a natural history of non-progressive disease over 2 years, and the patient agrees for a good compliance. Now, believe me, these two last lines are extremely important. Now, somebody has come from a distant village in Rajasthan to Jaipur, and you don't expect the patient to come back, and then you have to be extra careful or convince the patient that you need to be on a follow-up for 2 years before I can write it off that it's a non-progressive fibroadenoma. And it is not going to proceed to a giant fibroadenoma. If the patient is not so convinced, there is no harm in offering surgery to this group of patients. Coming to the third code area, nipple discharge, how to evaluate. And this is one area where I have seen, now this is a classical patient of 40 years, 41 years female coming with blood tint discharge. Clinically, it is serosanguinous, but the breast is absolutely normal. You palpate, you don't find anything. Radiologically, there is no abnormality, and somebody has written a nipple discharge for cytology. The question is, how certain and accurate is this nipple discharge cytology? Now, do they need intervention? Now, this was again our data, and it's a convincing data to prove. This was the study we had published where we could prove beyond doubt that discharge cytology does not help. I mean, if you get one drop of secretion to try to find out by pap smear whether there is a malignant cell is a fool's dream. So for God's sake, do not ask for discharge cytology. What you are going to use as a tool is an occult blood test. I mean, if you find that the occult blood test is positive, that is a baseline screening test by which you can tell, yes, you need a microdocectomy. Whatever the reasons are, I cannot tell you whether it's malignancy. The chances are only 10%, but a papilloma and duct ectasia might bleed to that extent and a surgery is required. Now, another important advice that I am going to give to the trainees is that once the patient is going off, do tell them that, madam, do not press your nipple. Now, very commonly what happens, they start pressing their nipple, and if they go to the lab, they also press the nipple. So what happens is that they incur micro trauma to the nipple and there is false positivity. So it should be a compression of the breast, and for that the patient should not be compressing the breast for a period of 7 days before they go to the laboratory, where the breast is compressed and squeezed from the periphery to the center without touching the nipple. And then if it is positive, that's a good enough reason to go ahead with the surgery. And this is the well-established guideline. If it's a multiple duct lesion, I'm sure it's not malignant and doesn't require anything. But if it's a single duct, and if you find the lesion, I mean a palpable lump, then it goes in a different direction. But if there is an impalpable lesion, you go for a breast radiology, you go for an occult blood test estimation or demonstration of RBC, and if you have one, you choose to go for either, as I said, a microdocectomy or a total duct excision. Now, breast cyst, when actually to intervene? Now, this is the core area 4. Now, look at this. This is about a 50 years female, because it's in the perimenopausal age group that it is very common. And with a lump in the right breast for 6 months, she attained menopause 1 year back. She was offered an ultrasound of the breast. Now look here, this is the ultrasound of the breast. And if you, again, trainees, look at this. This is a distinct lesion, and it's homogeneous. It's clear-cut, a fluid-filled balloon. And in these cases, you don't require anything. Only if the size is more than 2 centimeters, you can aspirate, or else just tell the patient, this is absolutely fine, you don't need to intervene. But look at this lesion on the left side. Now this lesion that you see here is a lesion which is more or less uniform, but on one edge there is a solid component. So once there is a solid component, it gives you the suspicion, well, it can be a malignant lesion, or it's a papillary carcinoma of the breast. And in these circumstances, you need a guided core biopsy from the solid component of the cyst to get the diagnostic yield. But you can add this. I was discussing about elastography, and look at this. Now, this same lesion, this is another lesion. You have put it on elastography, it turns out to be blue. And once it is blue, that means, and if you look at the kilopascal, it is quite low. That means this is a benign cyst and you don't require anything, just follow up. So as a problem solving tool, as I said, the new block, the new guy can always chip in to give you a diagnosis. So this is the guideline. As I said, the complex lesions requires ultrasound guided core. The unilocular lesions, you aspirate, ask the patient to come back after 6 weeks, re-aspirate. If it recurs after 2 aspirations, then a surgery is recommended. So as I said in the first part of our discussion, triple assessment is mandatory in patients with breast problems. Most of the patients with triple negative disease can be assured a non-operative treatment. Now again, for trainees, I must convey a clear-cut message. Quite often, we look at the plate, we find it's written BIRAD 2, you don't get anything, and you tell, okay, that's fine. For God's sake, before you tell that's fine, you don't need anything, go back after you have taken 5 liters of evening primrose oil and come back with a lump. You must be sure that you are not dealing with a malignancy, and therefore triple assessment becomes the center. The decision of non-operative antigen, as I said, must be evidence-based. And I remember the quote of one of my mentors, who always told in surgery and in benign breast disease, it is perfectly more relevant, that have faith on your 5 senses and triple assessment. Do not trust your 6th sense or gut feelings. We have seen people thinking that a 22-year female with a lump in the breast, "Are chalo yaar, ye to fibroadenoma hai," remove kar diya, then it came out to be malignancy. So for God's sake, unless you have got a convincing evidence, do not trust your gut feeling or the 6 senses and believe on triple assessment. Now I come to the second part of the discussion, and till now what we have been discussing is based on a robust evidence. And when we have a well-established evidence, it's a level 1, level 2 evidence, nobody's there to question you. When you have no evidence, you can choose to do whatever you like. But at times, there are situations where there are weak evidence or there are evolving evidences, and consensus is awaited. So in these circumstances, you need webinars that has been organized by the Rajasthan Association of State Surgeons of India to understand where the evidences are going. And this makes us come to the third and the last chapter, that is the gray zones in breast surgery. And I chose, apart from so many gray zones, something called a granulomatous mastitis, which is a new challenge for breast surgeons. I am sure if you have any breast surgeon or general surgeon sitting in the crowd, they must have encountered this new evil. And in many circumstances, it used to be easier for me to treat a cancer than a granulomatous mastitis, because the patient is going to come back after 1 year also with one more discharging sinus. So it is defined as a lesion which is clinically characterized by signs of inflammation and pathologically characterized by caseating or non-caseating granuloma. And the number one cause, blame it on Rio, whatever happens in India, people think it's tuberculosis. Now, these are the possible causes. And this was our initial data. And when we reclassified the data of almost 5 years, we found that only 15 were true tuberculosis. Rest all were idiopathic granulomatous mastitis. So this is a classical case of a lady who had multiple discharging sinus. We took a small biopsy from the wall. Somebody has done an incisional biopsy. It came out to be tuberculosis, with the patient would put the patient on anti-tubercular therapy, and after some time the patient came back with everything healed, and after 2 years the breast was absolutely normal and the patient required no surgery at all or no reconstruction at all. So think of what was there and think what the patient ultimately had if you are giving the patient a good anti-tubercular therapy. This is another patient, a post-mastectomy patient, where they had multiple discharging sinus. I didn't know what it was, and then finally I took a biopsy. It came out to be tuberculosis. We put the patient on anti-tubercular therapy and the whole scar healed wonderfully without any evidences of any residual lesion. So tuberculosis is present, but that's definitely not the commonest entity if it concerns breast. The commonest entity is idiopathic granulomatous mastitis. As you see, the term idiopathic means it is an autoimmune disorder. And I'm going to tell you why it is an autoimmune disorder. And it's just like sarcoidosis, and there is no point in using ATD. It is not going to help you. So we did this trial, a prospective observational trial. We have got the first publication done of idiopathic granulomatous mastitis and can we reach the end of the tunnel. And the aim of the study was to look at the pattern, the etiopathogenesis of IgM, to look at, again we are surgeons, whether there is any role of surgery, and to suggest a guideline based on the available evidences. Now, methodology was over a span of 2 years. We included all patients which were histopathologically confirmed as IgM and excluded patients with tuberculosis or multicentric lesion. That means lesions which involve the whole breast in different quadrants. They were excluded from the study. And this was the presentation. Most of you will agree that the commonest mode of presentation is like a chronic breast abscess. You do have patients coming with potheronge or ulceration, a simple lump presentation, which is not so uncommon in the West, is not the common counterpart as it comes to us. So we randomized the patient into 3 groups. Group A were put on steroids. Group B underwent wide local excision, and Group C underwent a new conceptual surgery that we have been able to come out and give to the world as such is wide local excision with duct excision. And what was the result? Now look at the result. Till 2017, we used to tell, for God's sake, if it's an IgM, put the scalpel into the locker, it's not going to help. Until in 2017, we re-understood the disease and redefined the role of surgery. So this was one of the patients, and my professor actually forced me to do the surgery. He was my mentor. He is almost 80 years. He told me, "Beta, ये कितने दिन इसको तुम steroid खिलाते जाओगे? इसको कुछ करो तुम." मैं बोल रहा हूँ मेरा वो ये है cousin का बेटी है तो तुम उसको सर्जरी करो. So I was forced to go under surgery, and I did a surgery where I excised the duct because it was communicating with the duct, and the result was fascinating. That gave me the validation understanding that I must do a trial on this. And then we set a hypothesis. The hypothesis is IgM is an autoimmune disease which causes ductal leakage. And what happens is the duct ruptures, and there is extravasation of irritant intraductal fluid, which is rich in cytokine, which causes periductal excision and destruction. And therefore, a total or a partial duct excision is likely to give a good response. It's just like a perianal fistula. You are treating, you need to take out the whole fistula structure, including the duct, to make it look successful surgery. So we randomized into 3 groups, and at the end of the study, we could convincingly prove that there was no recurrence in the group where we have not only done a wide local excision, but we removed en bloc, the total duct, all the partial duct was removed with a convincing statistical significance. And therefore, the next challenge that came to us, we must actually prove that there is a ductal communication, because you are doing a surgery based on, again, I must confess, based on your sixth sense, but you must prove that there is a ductal rupture. And therefore, we asked our pathologists that each and every case that I send it to you, you need to sort out with multiple sections whether there is ductal communication. Now, this is the duct, and you will find a non-caseating granuloma close to it with a rupture inside. Now, this is another patient with a non-caseating granuloma, and this is the duct. So what happens? The duct ruptures, and in the periductal area, this non-caseating granulomas form, and this is caused due to an autoimmune reaction. Now, why this autoimmune reaction occurs? Ladies and gentlemen, I am going to introduce you to this old friend called prolactin. Now, again, trainees, while I am giving this lecture, please do go into your Google and Google the role of prolactin apart from the fact related to breastfeeding. It is actually a cytokine. If it occurs in the local area, it works like a cytokine. There is actually a cytokine storm that happens in the breast in case of IgM, just like the COVID-19. And it is responsible, it's just like the Frankenstein. So the intraductal prolactin actually destroys the breast tissue, and it works as a Frankenstein. And why it occurs? It is because of the fact that the prolactin works through the JAK2 and the JAK5 pathway and the STAT1 pathway. As a result of which, look at the old culprit that we are being introduced. It actually promotes IL-6 cytokine release locally, which causes destruction of the breast parenchyma. And the cause is actually, this is how the pathogenesis takes place. Now look at this. This is the duct. The leakage starts, it goes out, it destroys the periductal tissue, and after that there is cytokine induced damage. So when we excise, this is the solidified ductal secretion that you will find. Now when you excise next time, please look that there you are going to find this greenish secretion coming out when you are excising a duct. In certain cases of microductomy, please note there will be a pasty greenish material coming out, and that is what is the irritant fluid, which is high in IL-6, and it causes the periductal destruction. So when you are excising, if you just go for a wide local excision, it is going to come back. The failure rate is almost 70%. But if you excise the ductal system with it, then the failure rate goes down to 0%. So it gives you a magical cure. So if you excise the fistula tract along with the total duct, that is going to be curative. So this is again an example of how we do it. It opens it up. We open it up, we take out the whole ductal system and take out all the duct underneath the nipple and then reappose it like the way. And you see here, the outcome, the long-term outcomes are excellent. The patient goes back. But the only issue, as I said, the exclusion will be if you have multicentric lesions, if you have in all the parts, that is somewhere where we are not going to go for this surgery. But lesions which are like these, or lesions which are like these, in these cases, this surgery, which is the recent advance I am suggesting, is going to be extremely beneficial. We got it published in the European Journal of Surgery, and last year I was invited to give this talk in the ABS, and I delivered this talk of idiopathic granulomatous mastitis. Now this year also it was accepted for presentation. We actually gave the randomized control trial results, but everything got through because of the pandemic, but it got published for the second time in the EJSO about our progress. So the conclusion is, it is an autoimmune disease, and prolactin polymorphism is the cause. That means there is a change in the character of the prolactin gene, which makes it autoimmune. It makes it Frankenstein. It liberates a cytokine storm. It leads to damage of the periductal tissue. Ductal leakage is therefore the key factor in progression of IgM, and total or partial duct excision with en bloc removal of the lesion is curative. Surgery, however, I put it with a mark of caution, is contraindicated in multicentric or in grossly infected lesion. In these circumstances, you just need to drain it and wait for the things to resolve and call back the patients on a later date after 2 months, and then you can go ahead with the form of surgery that I have suggested. So this is the shades of gray I was talking about. I am sure at the end of the talk, I am able to take you more from the black zone to something which is grayer, and hopefully we come out with more evidences, and we'd be able to give you the ultimate treatment guideline of idiopathic granulomatous mastitis. Thank you very much.
Thank you very much, sir. Thank you. Very nice talk. And sir, we are also now facing problem with the idiopathic granulomatous mastitis patient. We are also, the patients are coming to us. Sir, I have some questions.
Yes.
For you. And if clinically looking benign lesion, so you always go for core needle biopsy or FNAC is sufficient?
Madam, the policy that I follow and what is the international strategy is core biopsy. If a patient comes to me, a 22 years female, without any investigation done, I will offer an ultrasound and a core biopsy. If a patient has been referred by somebody, 22 years female, who has done an ultrasound which shows it to be benign and has done the FNA from a reliable center, I will accept that. I will not offer a core biopsy, but internationally, FNA is no longer recommended, madam.
Sir, if recurrence occur after wide excision of the granulomatous mastitis patient, then what we do?
Madam,
so recurrence is very high in granulomatous mastitis.
As I said, madam, if you are trying to do a wide local excision, it will fail. But if you do a total duct excision along with it, it will not fail. As of now, it was the initial trial. We have done more than around 70 now, and till now only in 2 cases there were small recurrences. In 68 of the cases, it did absolutely fine. So as I said, but you have to choose your patients. If it is multicentric, then just drain the abscess and wait for that whole breast to come down. If it's a very simple lesion, the patient don't want surgery, you can put the patient on low dose steroid, 5 milligram BD for some time. It fails, you can go for methotrexate. But as I said, young females, this occurs in the young female in the peri-pregnancy period. And if you try to tell them you need to put yourself on steroid for 1 year, and if it fails, then methotrexate, most of them would not accept it.
So there is one more question from the Dr. Swagat Kumar. What is the treatment of plasma cell mastitis with cystic dilatation of duct?
Actually, plasma cell mastitis in 5 minutes. Actually, plasma cell mastitis and idiopathic granulomatous mastitis, these are all part of a bigger spectrum. So it is basically, if there is a ductal dilatation with a mastitis, that means there is a ductal, somewhere the duct has given away and there is a periductal collection. So you need to excise the whole thing en bloc. So, but if, as I said, if it's a small lesion, you can put the patient on steroids. I have also tried with azithromycin, ofloxacin combination, and even trying with antitubercular therapy. The way it works is just the way it works in COVID. Azithromycin, hydroxychloroquine, doxycycline, they are immunomodulators. So they work as immunomodulators. They do not work as an antibacterial agent. So any form of immunomodulator is good enough. But if it is a nagging problem with a discharging sinus, as I said, the surgery is the best choice.
Sir, in steroid therapy, how long we can give steroid therapy? Whether there is any recommendation or time limit?
No, Bhavar, there is no recommendation or time limit. People have used it for even 1 year, and there have been evidences that after using for 9 months, they have stopped and the disease came back. So the West propagates the use of steroids because when they see such cases, they find it a very small nodule and they do a core biopsy and find it to be IgM. And in them, it is actually a spectrum of Wegener's granulomatosis or collagen vascular disease. But most of you, those who are seeing, they will see very ugly looking breast with multiple sinus in the breast, and it is an IgM. So using steroids in them will not help the cause. Rather, the infection is going to flare up. You need to control the infection and then take care of the duct system. So as I said, if you use steroids is for a very early lesion, non-progressive lesion, you can use it 5 milligram BD for a prolonged period, even 6 months, and then see. It's an empirical duration and empirical dose.
Sir, if there are multiple discharges sinus and we drain all these sinuses well, which antibiotic we will prefer for that?
Bhavar, as I said, these antibiotics, they do not help. If you have a culture sensitivity, you just give it. Most of the time, either they have used tons and tons of antibiotics after they have come to you because somebody, a local community physician, have given antibiotics for around 3 weeks, it has failed, and it has come to you, it looks like a chronic breast abscess. So in these circumstances, what I would suggest is that you be guided by the culture sensitivity report. If you use it, use empirically either azithromycin or doxycycline because they work as immunomodulator.
So, sir, as such, the drainage is sufficient.
For if it's an infected lesion, just drain the pus and wait for some time. If it's a non-infected lesion, in that case, and there is no discharging sinus, in that case, you can wait. But if there's a gross infection, that needs to be taken out.
Sir, we can give empirical ATT.
No, I don't. As I said, unless I get a definite proof of antitubercular therapy, I will not use it.
But in some literature, it is written that you can give rifampicin.
As I said, madam, I have used a combination of doxycycline with ofloxacin, with rifampicin, doxycycline with ofloxacin, with ethambutol. But the way it works is just like an immunomodulator. And the same way hydroxychloroquine acts in COVID. It's a cytokine storm modulator. It doesn't actually help on an antibacterial, antitubercular ground.
Okay. So there one more question. He's asking granulomatous mastitis with no clear lump. Should we give steroid or ATT?
ATD should not be given unless you prove that there is evidence of tuberculosis. But if you find there is no lump, it's a granulomatous mastitis, small lesion, somehow you have proved it, you can start with steroid. You need not go for surgery in these patients.
Sir?
Yeah.
A young female with granulomatous lesion in the lower part of breast with no ulcer or discharging sinus. What should be done?
If it's a lump only lesion, and you have put in a core biopsy and proved that it is idiopathic granulomatous mastitis, and idiopathic granulomatous mastitis, the hallmark is a non-caseating granuloma. If you find caseation, it is tuberculosis. So if it's a non-caseating granuloma, in that case, a lump only, you can put the patient on steroids for some time at least.
We can go directly on the basis of core biopsy, or we should get incisional biopsy.
No, incisional biopsy is not required unless there is a overt mass, which ulcer. You should not be going for, as I said, a core incisional biopsy.
Okay, thank you. Thank you.
Thank you. Thank you, Bhaur.
Thank you, sir. Thank you, sir, for your excellent lecture and eye-opening on the idiopathic granulomatous mastitis. And thank you for accepting our invitation. Thank you, sir.
It's an honor and privilege. Once again, a heartfelt thanks to you and Professor Shalu Gupta for giving me the opportunity to be part of. I don't know when the pandemic is over, and I am going to get the Rajasthani famous hospitality. Hopefully, the vaccine comes, we all meet and we enjoy without mask.
Definitely, sir. Definitely, we will.
Thank you.
Thank you very much, sir.
Thank you. Thank you. Thank you.
Now over to ma'am. Ma'am, anything want to say?
No, it's okay. Now we are end this CME.